A very good morning to professors, doctors, and fellow participants. Welcome to week 2 of the Emergency Medicine Seminar Series 2023. My name is Rabindran Jagaseagran, Medical Officer, Emergency Department, Hospital Chancellor Tuanku Morris. I'll be a moderator for today. Our topic of discussion for this week is clinical toxicology. We are fortunate enough to bring to you some of the best speakers in Asia to share their knowledge as well as related experience in the field of clinical toxicology. Okay, for our first speech today, I would like to call upon Dr. Patrick Tiglau. Dr. Patrick is an emergency medicine physician in the University of Philippines General Hospital. He is a pre-hospital care, wilderness medicine, as well as a resuscitative instructor. Dr. Patrick, the screen is yours.
Good morning to all. Hope you had a nice morning and had your breakfast. So, mabuhay, salamat pagi. Welcome to the 5th Emergency Medicine Seminar Series of 2023, a collaborative webinar series jointly organized by University Kebangsaan Malaysia, Universitas Borjaya, and University of the Philippines. We are on our week 2 covering the topics on clinical toxicology. We have excellent speakers coming from different countries in Asia to talk about different aspects of clinical toxicology. We hope that you will be able to learn a lot from our distinguished speakers as they tackle their interesting topics on clinical toxicology. And as we start, let me give you a small quote that you can teach a student a lesson for a day, but if you cannot teach him to learn, creating curiosity, he will continue to learn the process as long as he lives. We hope that you'll enjoy learning in our seminar series. Good morning.
Thank you, Dr. Patrick, for your opening speech. It's very enlightening. So, to start off, for our first talk today is titled Clinical Toxicology to Dose-Dependent Drugs in Japan, and it will be given by Dr. Ryoko Kyan. Dr. Ryoko is a graduate from Sapporo Medical University, Japan in 2003. She is currently a senior lecturer in the Department of Clinical Toxicology, Saitama Medical University, Japan. She has vast experience in the field of acute medicine, critical care, and clinical toxicology. Without wasting much time, the screen is yours, Dr. Ryoko.
Thank you. Good morning, everyone. Thank you for inviting me to this seminar. It is a great honor to present here. Thank you. Today, I would like to talk about a new abuse epidemic with old drugs that is becoming a problem in Japan. That is today's agenda. First, I will introduce our facility. Second, I will talk about drugs commonly abused in Japan. And finally, I will explain the problems related to abuse and dependence to OTC drugs, which is a particularly hot topic in Japan. I am a lecturer in the Department of Clinical Toxicology at Saitama Medical University Hospital. Saitama Prefecture is a slightly eastern area of central Japan. It is next to Tokyo. Our hospital is located in a town surrounded by mountains in the western part of Saitama Prefecture. In 2021, the Clinical Toxicology Center was established in our hospital, and at the same time, the Department of Clinical Toxicology was established in our university. The Clinical Toxicology Center has 3 divisions, namely Clinical Division, Research Division, and Education Division. In the Clinical Division, many poisoning patients are transported by ambulance from a large part of Saitama Prefecture. This is the only center in Japan with such a system. Variable cases encountered in this center have been reported in international journals like these. using the result of toxicological analysis. Now related to my main topic, I am going to talk about drugs that have recently become a problem in Japan. Let me start with the definitions of the terms on the slide. Drug abuse means self-use of drug against social norms. Drug dependence means a state of loss of control over drug use due to craving or a state of inability to stop drug use despite barriers in convenience in daily life and human relationships. Repeated drug abuse leads to dependence. If drug dependence continues, chronic intoxication develops, causing hallucination or delusions. I share some of the current overdose problems in Japan. This is a girl who overdosed on OTC drugs on the street and she cannot move herself. It spread on social media and made the news. These are the many empty bottles of antitussive pills left in public restrooms. Teenagers got together and overdosed. What's happening to Japanese youth? Here I will talk about overdose ingredient. In Japan, the most commonly abused OTC drugs are antitussives called remedies, analgesics, sedative or hypnotic, antibiotics, and drowsy medicines. None of these products require a prescription, and they can be purchased over the internet. This slide shows one of the characteristics of Japanese OTC drugs. Many OTC drugs in Japan are multi-ingredient formulations. This prevents consumers from paying attention to each ingredient. They also contain dependent ingredient. The Minister of Health, Labor and Welfare has designated these 6 ingredients as substances with a risk of abuse. Therefore, it is regulated that OTC drugs containing these substances should be sold in one package per person. Here, I will talk about some examples of substances designated as potential abuse. This is the most abused antitussive in Japan. It contains dihydrocodeine and methamphetamine. Each bottle contains 84 tablets, but sometimes they take a bottle or more at a time. This is the most abused cold remedy in Japan. It also contains dihydrocodeine and methamphetamine. This cold remedy also contains acetaminophen and caffeine. Young people share their overdoses on social media as if they want everyone to know how hard they feel. Look at the structure. They are very similar. Dihydrocodeine is produced by dehydrating codeine. As you know, codeine is an opioid that is also a product for morphine. As you may have noticed, dihydrocodeine in OTC drugs is classified as an opioid. This is the action of opioid. Opioid binds specifically to opioid receptors in the central nervous system and exerts CNS, respiratory, and circulatory depressant effect. Blood levels of codeine or dihydrocodeine exceeding 1,000 nanogram per milliliter produced some symptoms such as dizziness, somnolence, nausea, and constipation. Blood levels exceeding 2,000 nanogram per milliliter produce symptoms such as respiratory depression, seizures, circulatory failure, and even death. Moving on, I will show you about methylphenidate. Methylphenidate is produced by ephedrine. Incidentally, methamphetamine is produced by ephedrine. These structural formulas are very similar. These substances are categorized in ephedryl alkaloid. In CNS, ephedrine or methylphenidate cross the blood-brain barrier and exert CNS stimulation effect by promoting the release of neurotransmitters such as norepinephrine, dopamine, and serotonin. In the peripheral nervous system, they exert sympathogenic stimulant effect by promoting the release of neurotransmitters such as norepinephrine. In overdose situation, their CNS stimulant and sympathogenic stimulant effect are potentiated, resulting in CNS toxicity and cardiotoxicity. Here I will talk about non-regulated substances. In Japan, other OTC drugs which contain substances not designated are also abused. This is the antitussive frequently abused in Japan. It contains dextromethorphan. Dextromethorphan, a metabolite of dextromethorphan, is more pharmacological active. This is the action of DXM and DXO. Their action profiles are complex, with markedly different effects depending on the dose ingested. At therapeutic doses, side effects are minimal, while at higher doses, it acts as an NMDA receptor inhibitor and serotonin agonist. Here, I will talk about the symptoms that vary with the amount of DXM used for recreational purposes. They call each a plateau depending on the dose. In plateau 1, MDMA-like symptoms such as euphoria. In plateau 2, ethanol plus marijuana-like symptoms such as visual hallucination. In plateau 3, low-dose ketamine-like symptoms such as out-of-body dissociation. And in the plateau 4, ketamine poisoning-like symptoms such as complete dissociation may be experienced. The variety of experience that legal drugs enable, such as illegal drugs, may be one of the factors that interest young people. This is the sleep support frequently abused in Japan. It makes use of the drowsy side effect of diphenhydramine. This is antiarrhythmic frequently abused in Japan. These drugs contain diphenhydramine too. You have probably heard the sad news about the Benadryl challenge. The ingredient in Benadryl is diphenhydramine. Diphenhydramine is well known for its anti-allergic action as a histamine 1 receptor antagonist. In addition, it is a muscarinic receptor and dopamine receptor antagonist and also blocks phosphodiesterase channels. In overdose, the effect of anticholinergic, sedative, and kininogen-like effects are potentiated. Interestingly, the anticholinergic effect appears stronger in children. In contrast, the sedative effect appears stronger in adults. Diphenhydramine also has different symptoms that appear depending on the dose. Consumption of less than 300 milligram result in mild poisoning with symptoms of lethargy, tachycardia, anticholinergic symptoms, and vomiting. More than 3,000 milligram result in moderate poisoning with symptoms of irritability, excitement, delusion, and confusion. And more than 1,000 milligram result in severe poisoning with symptoms of delirium, psychosis, seizure, and coma. This is the anti-drowsy medicine frequently abused in Japan. It contains caffeine. The intoxicating dose is at least 2 grams, and the lethal dose is at least 5 grams reportedly. There are no regulations for supplements of 300 milligram per tablet. Therefore, they can easily get lethal dose. Here is the action of caffeine. Caffeine has a wide variety of pharmacological effects. In overdose, these pharmacological effects are potentiated. Potentiated CNS stimulation effect result in tachypnea, irritation, excitement, psychosis, and seizure. Myocardium stimulation effect result in sinus tachycardia and ventricular arrhythmia. Diuresis result in hypokalemia and hypophosphatemia. Skeletal muscle stimulation effect result in lactic acidosis and rhabdomyolysis. In the last chapter, I will talk about the problem related to OTC drugs in Japan. This figure shows the ratio of patients who are primarily dependent on OTC drugs who visit psychiatric facilities in Japan. The ratio increased approximately 6-fold increase within 8 years. This shows the annual change in the ratio of primary drugs of dependence. In 2014, about half of patients were dependent on novel psychoactive substances. Then the ratio of novel psychoactive substance dependent patients declined rapidly, mainly due to increased enforcement. However, the ratio of OTC drug-dependent patients, which had been almost non-existent, increased rapidly. In 2020, more than half of patients were dependent on OTC drugs. This is the ratio of primary drugs of dependence for patients who present at psychiatric facilities in 2020 in each age group. It showed that the younger generation is more dependent on OTC drugs, while the older generation is more dependent on hypnotic and anti-anxiety drugs. These events also occur in regular emergency room, not in specialized psychiatric facilities. This figure shows the annual change in the rate of drug overdose among patients transported to our center. The large figure is the teenagers. In 2020, overdose of OTC drugs were the cause of 16% of acute poisoning cases in teenagers. What have been done to solve the problem of OTC abuse and dependence in Japan? We believe that one of the causes of these repeated overdoses of OTC drugs is the dependence on the ingredients. To solve this problem, it is necessary to review the ingredient and develop new sales method. And there is another important thing. Young people who have difficulty living with various psychosocial problems, but somehow manage to lead a social life, overdose on OTC drugs as a means of suicide, as well as to relieve discomfort or to forget their painful situation. It is also necessary to look at the environment of young people, to listen to their voice, and most importantly, to get to know them. In order to solve these problems, we need to share the fact and cooperate with not only physicians and healthcare providers, but also government, educational institutions, drug companies, and distributors. This is the end of my presentation for today. Thank you so much for your attention.
Very much, Dr. Ryoko, for your presentation. Very enlightening, and looks like all of us got to stop drinking coffee from now.
Thank you.
Okay, for our second talk today, entitled Updates in Recreational Drug Use and Its Toxicity by Dr. Chan Wei Ling. Dr. Chan is a senior consultant and a clinical toxicologist in the emergency department of the Khoo Teck Puat Hospital in Singapore. Her clinical and research interests are recreational drug toxicity, prescription medicine misuse, disaster preparedness, and management of chemical incidents. Without further ado, I invite Dr. Chan for her talk. The screen is yours, Doctor.
Hi, good morning, everybody. Thank you for the kind introduction. And also, I'd like to thank the organizer for inviting me to speak at this seminar. So my name is Ling, and today I'll be talking about updates on recreational drug use and toxicity. So this is an overview of what I'll be covering today. We'll first look at the different types of recreational drugs, looking at some global trends of use and misuse, and I'll end off with some case studies. So as we're all aware, recreational drugs can be divided or classified based on their clinical effects into these three common categories, namely stimulants, hallucinogenics, and depressants, which is on the left of this chart. And in the middle column, you can see the classical recreational drugs, which most of us are familiar with, things like amphetamine, cocaine, ketamine, and heroin. Then to the right of the screen, this is the entire long list of new substances, which the first speaker has also mentioned. They are known as de novo psychoactive substance. So these are substances that the chemist has actually created. So they took the molecule of the classical drugs, which is illegal, and they make some change to the sidelines, or they add on things to the chains, to the molecules, and they create a new molecule, and hence this is how they actually evade drug regulation and legislation. So a little bit more about novel psychoactive agent, NPS. So they are commonly known as legal high, bath salt, or research chemicals. So legal high is actually a misnomer. As I described earlier, it is legal because the chemist has taken an illegal drug, made some changes to the molecule, and created a new molecule, which is currently not classified as a controlled drug. But this is a misnomer because it gives the user a misconception that it is legal and hence it is safe to use. It is also, NPS can be easily available in the dark net or internet under these names like bath salt, research chemical. So, they will say buy research chemical, buy benzofuran, at this amount for this kilo, and they'll actually put a tag there to say, oh, it's not for human consumption. So with the ease of internet access these days, these chemicals can be brought easily over the internet. So how do they present or cause problems to public health? As mentioned earlier, it's easily available. The user would think that there's less social stigma associated with its use, because they think that it is not in the list of the classified drugs, so there is little health threat. Also, some people may perceive that because it's not controlled drugs, there is less of a social stigma to use these drugs. And last but not least, actually is not detected or very hard to detect in routine drug screens. So people can take it, and if we are not sure what they are taking and we send off just the routine drug screen, they will not be picked up. Most of these drugs. Okay. And what are the problems associated with MPSs? So even though the drugs are new and the health effect or the effects on human being is not that well studied, there have been reports of these MPSs causing quite bad side effects such as seizures, agitation, aggression, acute psychosis, dependence, and death. So what happens sometimes is when these MPSs, there's enough cases that they are actually very harmful, the drug legislation will then make these MPSs illegal, these known ones, which is why the legislation and the creation of drug is like not a cat and mouse chase, and the legislation is always after the chemists, because they are very quick in changing the molecule once a certain drug is made illegal. So now we'll actually look at the global drug trend. So this is actually information from the UNODC World Drug Report 2023. So as we can see, in 2021, 1 in every 17 person aged 15 to 64 has actually used a drug in the last year. And this is actually quite alarming, because compared to 10 years ago, this is 23% increase in drug use, in the prevalence. And as we can see, the most commonly abused drugs, which is not surprising, is actually cannabis, followed by opioids, amphetamine, cocaine, then ecstasy. So what about us in this region? How is our drug use trend like? So as many of us, or all of us are aware, very close to us, Thailand, they actually have legalized cannabis in the recent years. So you can see actually, food products, be it cakes, drinks, being laced with cannabis. And there are many pop-up stores, cafes, cannabis stores and cafes that pop up in Bangkok. So what is this effect on Thailand? So I've spoken to some of the Thai toxicologists. They have shared that, this is actually impacting their healthcare system. And this group, Resmond and Surya, they actually have published recently about the trend of cannabis use and harm after legalization. So not surprisingly, cannabis use has increased. And also what is actually more worrying is there's an increase in prevalence of smoking of cannabis in the younger age group, those aged between 18 and 19 years old. And the symptoms of cannabis use disorder has gone up a little bit, but then went downhill in 2021. And also the other thing to take note of is after they've done the survey, they realized that close to about a third, 36% of them believe that cannabis is actually a cure for some illness like cancer, and up to 23% they didn't believe that actually cannabis is bad and they can get addicted to cannabis. So this is actually quite a big problem, because they are using the drug without knowing that it's actually harmful. So what about drug use trend prevalence in Malaysia? So in this research, this is actually a interviewer administered questionnaire to Malaysians aged 15 to 40 years old in the year 2020 to 2021. The prevalence of lifetime drug use is 5.5% in this study, and the commonly misused drugs are kratom, cannabis, and amphetamine type stimulant. So just something to note, kratom and cannabis are actually currently legal in Thailand. So what about Singapore, the country that I come from, where we are known for our tough stance on drugs, and our CMB aim or mission is actually for a drug-free society. We shielded from this emerging phenomena of drug use and misuse in this region. So unfortunately, we are not. So this is a drug report released for last year, 2022. There is actually a 71% increase in cannabis abuser being arrested. And a worrying trend is out of these cannabis abusers who were arrested, 2/3 or 71% of them are actually new abusers, and they actually fall below the age of 30 years old. So they're actually quite young abusers. So this is quite a worrying trend, and we are not sure if this is also what the youth are actually thinking, their thoughts. Because with more and more country normalizing the use of cannabis, we are worried if this has actually changed their perception of drug use, thinking that it's actually safe or okay to use. So this is what we are worried about. And based on the drug report released by CMB last year, the most commonly abused drug is methamphetamine, followed by cannabis, ecstasy, prescription medicine, and last but not least, MPSs in Singapore. Based on drug seizures, so CMB also conducts raids. So as we can see in this slide, we actually can see cannabis plants being confiscated from flats. So people are actually growing cannabis in Singapore. And we also find candies and very colorful packaging, like sweets being sold. And these gummies are actually laced with cannabis and illicit drugs. So this is another worrying trend because they are very colorful, attractive. So the young, especially the children, may not be aware that they are actually taking illicit drugs. So they may think that these are actually candies with no harm. So some local data from some research. This is a online survey which I've performed in the 2015 to 2016. It's an online survey, and it is found that actually prescription medicine misuse and recreational drug use is actually significant. Its use is significant in Singapore. So among the prescription medicine, the commonly misused drugs, which is benzodiazepine, diazepam, and opioid-containing medicine like codeine and Decidil. So this is quite similar to what our Japanese colleagues have shared earlier today. And in terms of recreational drugs, it is cannabis, followed by cocaine and MDMA. And more recently, there is a larger survey conducted by the Institute of Mental Health, IMH of Singapore. So this time they interviewed more than 6,000 patients, and they found that close to about 1.7% of the people staying in Singapore actually have used drugs in the last 12 months, despite drugs being very difficult to get in Singapore. And just like the drug report released by CMB, the worrying trend is the mean age of illicit drug use is actually 16 years old, which is very young. And close to 42% of them actually started the drug consumption before they reached 18 years old. So again, this is something that we need to look at in terms of preventive program and to actually hopefully prevent our youth from trying out drugs at a very young age. So from this study, again, cannabis is the most commonly misused illicit drugs. So next, I'll move on to some case studies, which we've seen in the A&E on our day-to-day. On our day-to-day, and I'll talk about the management. So first, we have a standby case for drowsiness. So this is actually a 28-year-old gentleman found collapsed in his car with bottles of brown liquid. His pupils were small at 2 millimeter bilaterally. He's hypoventilating, slightly bradycardic, and he's very drowsy. He only responds to pain. So what is the possible diagnosis? Do you recognize any tox syndrome? What do you think can cause his presentation? What drugs is responsible? Is there any medication or antidote that can be administered? So as we all know, this is actually a opioid tox syndrome because he's got a respiratory depression, CNS depression, his pupils are small. And the drugs that's possibly responsible ranges from prescription medicines such as heroin, opium, okay, to the newer drugs such as the MPSs, the novel opioids and fentanyl analog. So the antidote is the naloxone. So why do I bring up this case? First and foremost, we need to be aware that naloxone has a very short half-life. So these patients, if they are very severely poisoned, they will need, some of them will need a infusion to actually keep them to prevent them from going to respiratory depression. And they need to be monitored in a monitored care area. And also, this is actually the MPU that some of us have grown up, seeing. Last time when we asked for naloxone, it comes with an MPU or a plastic MPU or glass one where we break and we give as a bolus, either intravenous, intramuscular, or via the ETT. But if you actually look at the base at the bottom of this slide, we actually have got naloxone in many formulations these days. There's actually the first two on the left is actually intranasal spray, and the one on the far right is actually auto injectors. So why is there such a wide range of naloxone formulation these days? And in overseas countries such as Canada, the family members and even first responders are actually being trained. Okay, so they have these drugs either at home or with them, and they have been trained to know when to use and how to use these drugs. So why are our Western counterparts having to supply the first responders and some family members with naloxone? The reason is in the Western world, they're actually fighting a pandemic, and it's not an opioid pandemic. It is actually, it's not COVID pandemic, it's actually opioid pandemic. So based on the World Drug Report in 2023, opiates continue to be the group of substance with the highest contribution to severe drug-related harm, including fatal overdose. So as you can see on the graph on the right, there is a steady increase in the number of cases of death that's related, also drug-related death in the United States, and of which opioids is the main contributing drugs, which is why the family members of the abuser or the drug users and the police are actually trained to know when to give and how to give. This is in hope of saving more lives and prevent death from opioid overdose. So what about Singapore? Do we have a problem with opioid overdose? The answer is yes. And similar to what our Japanese colleagues has presented this morning, we have a problem with opioid-containing cough mixture use. So the HSA, which is a health science authority in Singapore, they have done drug seizures, and they have seized lots of codeine-containing cough mixture in their operation. And also doctors have been censored, in recent years for the sale of, either large amount of codeine to actually drug abusers. And the HSA, so they also found in the last 2 to 3 years that there is actually an increase in number of cases that are tested positive for codeine in the drug samples that is sent to them. So this is a graph to show that once the drug samples is positive for codeine, they ran the analysis, HSA ran the analysis, and they found that actually there is a whole list of drugs that is found in these drug samples that were tested positive for codeine. So in these drugs, in the blood of these patients, we found many other prescription medicine and also illicit drugs such as nitrazepam and amphetamine. So if you look at the blue box on the right, these are the cough mixture that is registered for use in Singapore. So we can count the number of ingredients, and we don't have that many. Besides codeine, there are 7 other ingredients like paracetamol, promethazine, diphenhydramine that's mixed into cough mixture. I mean, that's mixed and sold together as a cough mixture in Singapore. So we can see that, in the illegal or illicit cough mixture that is obtained locally, the patients are actually at very high risk of polypharmacy abuse or overdose, because HSA actually found a lot of other drugs in the drug sample. And back to our patient. So what do we find in the blood sample of our patient? So we have found things that are sedative, like benzodiazepines. There is opioid containing medicine. And interestingly, there is this drug called carisoprodol. So a little bit about carisoprodol. Carisoprodol is actually not registered for use for therapeutic use in Singapore. So how does it work? Okay, it is actually metabolized in the body to meprovomite, and meprovomite is also a sedative and hypnotic drug. So users has reported if they take maybe 1 to 3 tablets, they actually feel a bit, cheerful, more awake. Take a little bit more, they feel euphoric. There's a sense of reduced inhibition. However, if they take a lot more tablets, they can go into agitation and confusion. So carisoprodol, which is found in the drug screen of our patient, is actually not registered for use in Singapore. Another drug that is not registered for therapeutic use in Singapore is serpentalol, and this has also been found to be present in the recent drug screen done by HSA. So serpentalol is actually an opioid analgesia. Its structure is similar to tramadol, which is also one of the commonly misused prescription opioids, especially in the Middle East. And in recent years, drug seizures has also picked up serpentalol in Singapore. So this is a trend that HSA is also watching on the misuse of drugs. So next, we also move on to another case of drowsiness. So we actually have a 28-year-old gentleman who was sent to the A&E after he was involved in a road traffic accident. He fell asleep, drove the car into a tree by the side of the road. Because this is a trauma case and he was hypotensive, so he was intubated. Fortunately, the trauma survey, or surprisingly, the trauma survey was unremarkable. The bedside ultrasound showed that there was no free fluid. So again, his presentation, he was hypoventilating, small pupils, bradycardic. So what's happening? So because we have to strip the patient for trauma survey, we found a small bottle of clear liquid found in his underwear. What is this clear liquid? Okay, I'll talk about this a bit later. But for this patient, we proceeded to actually do a CT scan, pan-CT scan, which turned out to be unremarkable. He was admitted to the surgical ICU for observation. And within the next 6 hours, he actually woke up, self-extubated, and was discharged against medical advice. So what is this clear liquid? So this clear liquid actually contains GHB, gamma hydroxybutyrate. So it is GHB is actually highly addictive. It's commonly known as G, and it's sometimes sold as liquid ecstasy, known for its euphoric effect and has no relations to ecstasy itself. So why do people use GHB? Because at low dose, they actually feel that they are more relaxed, it's pro-sexual, and they actually reduce inhibition. But there's a very narrow therapeutic index. So when they drink small amounts, they feel good, they feel high. But if they continue to drink, sometimes they may overdose without knowing, and they tip into a very bad coma with some respiratory depression unknowingly. And sometimes what these drugs are actually quite common in the men who have sex with men community, or so they bring it to the club, they decant it into a water bottle, and because it's clear, sometimes what happens is instead of drinking water, they think they're drinking water, but they take a very big gulp, and this is actually GHB, and they turn unconscious. So as I mentioned, it's a very narrow therapeutic index. The management of GHB patients, actually are mainly supportive because the effect comes on really fast and it wears off very soon. Within this 4 to 6 hours, the patient usually wakes up. However, when they are deeply comatose, sometimes they can aspirate, they can go into respiratory depression, which is why it will be better, they do better if they present to healthcare facilities. So in healthcare facilities who are used to seeing these patients, like the center which I worked in previously in London, what they do is they recognize that this is a potential G misuse or intoxication. They will lie the patient on the left lateral and keep them under close monitoring to make sure that they don't aspirate or go into worsening depression. And they usually will walk out like our patient after 4 to 6 hours. However, in centers that are not that don't see that many cases, the physician usually panic because they are very flat and comatose. So these patients gets intubated too. And like our patient, when G patients is intubated within 4 to 6 hours, they usually self-extubate and they will get out of the hospital. So next, we'll look at another case of AMS. So this time, again, we are looking at a G user. So this G user presented to the A&E. This time, he's not, he doesn't have a poor GCS, but instead he's gone on to the other spectrum. He's severely agitated and anxious. He's seeing and hearing things. He's slightly tachycardic and hypotensive. So what is the diagnosis and what treatment would you consider? So a bit more about G. GHB actually acts on GHB specific receptors and on GABA B receptors. So with chronic use like alcohol, tolerance happens, and this is associated with downregulation of inhibitory GABA and GHB receptors. And when the patient goes cold turkey or they do not have enough G, what happens is then this neuroinhibition gets reduced and the patient ends up with an unopposed excitatory neurotransmission, as commonly known as a withdrawal symptoms. And this is actually similar to alcohol withdrawal. The only difference is that the neuropsychiatric manifestation in GHB withdrawal is more pronounced. They last longer, up to 2 weeks, and they're very resistant to benzodiazepines. So sometimes they need to use high-dose benzodiazepines. So what are the red flags for a patient, a G user, to go into withdrawal? Similar to alcohol, we will ask them similar to alcohol, we'll ask them questions like, oh, do you need to wake up and use G? Are you able to cope? How many hours can you cope without using G? And when was the last time you actually had G? So if the patient says that no, they need G every like an hour, 2 hours, or they need to wake up, and if they don't have G, they can't function, then these are patients with very high risk of withdrawal if they do not get their regular G. So what are the symptoms of GHB withdrawal? It's similar to alcohol withdrawal. In the initial stage, it's nausea, vomiting, a little bit of confusion, and in the next 24 to 48 hours, they actually turn very agitated, tachycardic, and very bad paranoia and hallucination. So how do we manage this patient? Again, they need to be monitored in the monitored care area. We use high-dose benzodiazepine, which is a GABA A receptor, and we also add on Lacofan, which is a GABA B receptor. For the very severely intoxicated, for the patient with very severe withdrawal, some of them actually require intubation. And I've seen cases where they are actually intubated for at least a week for the withdrawal effects to wear off. So our last case is actually a case of agitation and again of agitation. So it's a 28-year-old gentleman that's brought to the A&E complaining of breathlessness. He's inhaled poppers 2 hours ago at a dance party. So these are his vital signs. He's slightly blue. So what are poppers? They are not the picture that is shown on the right bottom. So poppers are actually made up of alkyl nitrites. They are commonly used by, let's say, in dance festivals or in parties by young teenagers because they are easily available again. Sometimes what they do is they transfer from this canister into a balloon and they actually inhale for the balloon to get high. So this canister can be bought online, like the whipped cream canisters, for example. So these are actually easily available. So what happens is in nitrites, they actually oxidize the ferrous iron to ferric iron in hemoglobin, and this reduces methemoglobinemia, which is why the patient is blue. In mild intoxication, they do well with just oxygen, but in severe cases or symptomatic patients, we may have to give methylene blue. So this is an acute problem with the use of party poppers. They are usually seen as safe, but actually with chronic use, they are not that safe. So nitrous oxide actually exhibits its neurotoxicity and the patient can present with very non-specific signs of neurological complication. They can present with unsteady gait, numbness, weakness, or even falls in young adults. So how does nitrous oxide actually cause harm? So we can see that nitrous oxide, it actually inactivates vitamin B12 by oxidizing the cobalt ion in vitamin B12. So when this happens, the homocysteine cannot be converted into methionine, and methionine is actually needed for the myelination of our nervous system. So in chronic users, demyelination of the peripheral and central nervous system can happen, which is why they present with very non-specific neurological complication. So like I mentioned, the symptoms can be non-specific, so we do need a high index of suspicious. The B12 can be normal because it's a functional deficiency, so we need to check the methyl malonic acid and homocysteine level, which can be high. So early diagnosis, cessation of use, and treatment with hydroxycobalamin are critical to reduce the neurological damage. So what lies ahead of us is going to be an uphill task with regards to drug use because, as I mentioned, drugs can be easily available via the darknet. Also, with the implication of legalization of cannabis in our region, we will expect increased use, especially in young who are very adventurous. And of course, with the never-ending creation of new novel psychoactive agents, this is another problem. So recently, there is actually a trend of getting synthesized, cannabinoids being synthesized from a non-psychoactive substance in the cannabis plant, and this is actually known as a CBD. It's sold as in the vaping liquid, or it can be put on food products. And actually, there have been reports that there's actually quite a bad health outcome when patients use these new drugs, the CBD. So, in conclusion, recreational drug use prevalence is increasing. So, diagnosis is based on clinical symptoms and signs and clinical presentation and signs and symptoms. As the drug level will take, number one, it may be hard to get and it may take a while to come back. And with the increased use of a range of synthetic new drugs, this will also give us, the physician, a challenge. So attending physician will need to be more cognizant of these drugs, their manifestation and treatment, so that we can help treat our patient earlier to prevent more adverse outcome. So before I end, I'd like to thank Paul and David from St. Thomas for the use of some of their data, and Dr. Yao Uju from HSA for sharing some of the HSA data with me too. So thank you very much for your attention. Yeah. I think in the chat box, someone has asked whether our serum drug testing done in all substance abuse case in Singapore. So again, this is actually, the answer is usually yes, we would go to, let's say if the patient presents to the A&E and we suspect drug use, we'll take the blood from the patient and send off the blood samples to the Health Science Authority for testing. So these are patients who come into the hospital. Of course, those who are apprehended by police for suspected drug use, these will also, for these patients, it's mandatory that they have their drug tested.
Okay, thank you, Dr. Chan, for your presentation. Based on your presentation, it feels like the battle against recreational drug use is getting harder and harder these days.
Yeah, it is because it's hard to control. Yes. And yeah, a lot of people are actually using drugs, and with the legalization of cannabis everywhere, I think it's going to be an uphill task. But I think it's something that we need to look at because the effects is actually quite profound, and especially in the young group, they may go on to take drugs not knowing that they are harmful. So the education and preventive measure will be what we need to work on quite a fair bit.
Okay. Thank you again, Dr. Chan. I would just like to ask Dr. Chan to stay on screen. So, to dear participants, due to some unforeseen circumstances, Dr. Chan will not be able to join us for the physically for the forum session later. So, she'll be answering all your questions now. If there are any questions beyond the next 5 and 10 minutes, she will answer it in the Q&A session later. So, Dr. Chan, actually, I have a question for you. What is the most severe presentation of cannabis overdose actually that you have seen in your emergency?
Actually, in cannabis, it's actually not too fatal. So a lot of times they come in with like the stimulant kind, so agitation, tachycardia. Sometimes they do have chest pain. So yeah, this is more like the acute manifestation, but I've seen patients with chronic abuser, they actually end up with cardiac complication.
Okay.
So acutely is some dose of benzodiazepine usually will come down. It's not too bad, but with chronic use, they can have some health effect. And of course, with some cannabis, I have a case where we suspect that it may not be cannabis, or it could be mixed with other substance. The patient actually presents with a chest pain, and the ECG actually shows ST elevation with no reciprocal changes. But so in the end, we still gave the patient some benzos, but we activated the cath lab, and the coronary angiogram actually shows that the vessels were normal. So this is mostly because of the vasoconstriction of the stimulant drugs. But we don't think, for that case, we don't think it's purely cannabis. We suspect it may be something more than just cannabis that the patient has taken.
I understand, Doctor. Doctor, for your next question, should marijuana be legalized? With the increasing role of marijuana, medical marijuana for treatment of neurovascular diseases as well as for chronic pain, do you think it should be legalized in Singapore?
I think in Singapore is it has been a very how do I say, the stance against about cannabis has always, the legalization of cannabis has always been such that there's no rule for medical cannabis in Singapore. Yes.
Yes. So I guess it's a big no lah.
Yeah, I think so too. I don't think it will happen in Singapore, and I think as of now there are other drugs that the physicians are using to treat all these conditions. So I think no one is lobbying for legalization of cannabis in Singapore at this current point in time.
All right. Doctor, for the third question, okay, so it's actually a three-part question. This whole three-part question regarding cannabis. So, do you have any advice for a country which plans to legalize cannabis? What are the public health matters that the government should pay attention to?
I think I can't say for sure, but based on my conversation with my Thai colleagues, so I think a lot of thoughts has to be a lot of thoughts has to be put in place, because in this country, like for example Thailand, what they see is once cannabis is actually legalized, they have a huge jump in people trying cannabis, and the more worrying trend is actually the young, be it children and young adolescents, who may not be aware of what they are doing or trying, and they go on to take cannabis. So I think the health preventive measures, in terms of education, needs to be. I guess it's difficult because it's easily available, and because it's legalized, right? It's just like teenagers trying to smoke. It's something that eventually people might do it because out of peer pressure, or they think it's a cool thing to do. So I think it has a lot of implication, and of course the worrying trend is if they start to use drugs at a young age like cannabis, then will they move on to harder drugs, or the MPSs as they get they get more.
They say cannabis is a gateway drug, right?
Yes,
it's a gateway
so
drug.
I think that yes. So in that sense, I think a lot has, I think we can watch the development in Thailand to see actually, what will happen next. But actually based on the data that is shared by the CND with locally in Singapore, even though we are quite tough on our drug stance, like the last year's drug report which I've shared, there was actually increase in people which are caught using cannabis. So a 70% increase is actually very significant. So this may be the tip of the iceberg, which means that so having legalization of cannabis not even within my country, but in a nearby country where may have. Well, I'm not saying that's the reason, but we are postulating that could be one of the reasons why there's a sudden increase in cannabis use. Abuser that have been caught. So I think the effect will not only be in that country, but in the neighboring country too.
Understand. Doctor, we got two more questions in the chat box. The first one is, do you see a lot of cases of cannabis-induced gastritis? And if you have, what is the treatment for cannabis-induced gastritis?
No, actually, in Singapore, we don't see that many, but I did a fellowship where I had spent about 1 year plus in London, where I work in St. Thomas, and we do see quite a lot of druggies there. There isn't that many cannabis-induced gastritis. They may just feel a bit. Usually, it's more like a bit of nausea, but mainly it's mainly the stimulants, like they get a bit of tachycardia. Yes. So I think if it's treatment, I mean, most of the time, I mean, I haven't used any of the but most of the time it's symptomatic, like drip and antiemetics. Yeah, nothing out of the
So it's
ordinary
more
from
symptomatic
my
treatment, more of symptomatic
Yes.
treatment. Understand. Oh. Doctor, the last question. Is there any primary blood screening panel for patients suspected with GHB overdose? And so besides from relying from clinical examination, is there any primary blood screening panel?
So GHB actually is a drug that's very hard to screen for because the half-life is very short. Like I've mentioned, you can have a patient that's totally knocked out, and within 4 to 6 hours, if they're intubated, they can self-extubate. So for GHB, unless the patient presents like that case, where they present and you suspect you have a very high suspicion index of a GHB, you take the blood when they are down and you send it for screening, then you may get it as positive. Whereas if you wait a little bit longer, you may not be able to pick it up. So in the overseas centers, I know they have been doing trials on using sweat or even oral sticks. So what they do is they actually have a stick, the drug user actually suck on the stick or just rub it in the oral mucosa, and then they try and do testing for GHB. So these are all works that they've done, but I think right now there is no point of care test for GHB yet. So I would say that the GHB, if you do suspect, the blood has to be taken early and sent off. Otherwise, you may not be able to find the product. The half-life is very short.
So regarding GHB again, doctor, there's a question in the management of withdrawal of GHB. Up to 150 mg of benzodiazepines may be used. So how fast do we administer this much of benzodiazepine, or do we prefer giving IV diazepam or IV midazolam in these patients?
So if the patient, we don't give at one go 150 milligrams. So what happens is accumulated dose. So some of these patients may come in just in the initial stage where they are a little bit agitated or they have a bit of paranoia. So these patients, sometimes what we'll do is we'll give them the oral tablets. Of course, if it doesn't work and it gets very aggressive and agitated, then we may have to give the intravenous form. And how do we give, how much, and how frequent do we give? It's similar to alcohol withdrawal. So we actually use the CUR score, which we use for alcohol. We will score the patient and then we will give the benzodiazepine accordingly. So this is actually accumulated dose. For example, it is not at presentation a set dose of 150 milligrams of vitamin.
Understand. And we have a few more questions, doctor, if you don't mind. For opioid overdose, how do you titrate the naloxone being given? Doubling the dose, for example. Is there any specific cutoff for starting the infusion? Or do you
So
just
yeah.
and
Okay.
basically they ask
Yeah, I saw the question. So
yeah.
for naloxone, what happened is we can give a bolus. So we can give 0.4, 0.8, 1.2. So what's the endpoint of reversal? It's not to full GCS, but it's so that, if they are obtunded, they've got very poor RR, like a respiratory rate of like 8 or 9. So we give the naloxone till the respiratory rate improve. So what we are aiming for is to reverse the respiratory depression, but not aiming for full GCS. So if you have the luxury of being able to monitor the patient closely, the patient is now breathing on his own, and we do know the drugs, then sometimes if it's, if the reversal takes place with a 0.4 or 0.8, then you may say, oh, it's not a lot. You may just want to monitor the patient. But if it's unknown drugs and, with all these novel opioids or fentanyl analog that is in the market, if you're worried that this could be something that is illicit and has a longer half-life, or the patient requires a lot of naloxone for reversal, then what we'll do is we'll start an infusion. Yes. So that's the time where I would say we'll start the infusion, but all these patients actually needs to be admitted to a medical monitored unit. So depending on the hospital that you work in, sometimes this may mean a general ward with closer monitoring, or it may mean the high dependency unit. So why do we need to monitor the patient in monitor area? Because one is to titrate the naloxone infusion. We need to sometimes increase or reduce. And also, sometimes if you give too much of naloxone at one time, then the patient can go into withdrawal. So they actually do need monitored care when they are on naloxone infusion. Yeah.
So is there any protocol placed for this naloxone administration?
In the center that I work in, again, it's up to, they can actually consult the clinical toxicologist on shift. If not, then yes, it's usually, we will say if we give high enough dose, you're worried that the patient will go back into respiratory depression, then the advice is always to start an infusion hourly and monitor, so you can down titrate as the patient wakes up. That would be a safer way.
Doctor, do you see any cases of substance abuse from vaping?
Anecdotally, the answer would be yes, because we do know of people who present with in suspected overdose. Yeah, but unfortunately in Singapore, because of the tough drug stance, the public or patients are not very open to sharing with us. They are more open now than maybe 10, 15 years ago when I was working. Yeah, but still, they're not so forthcoming. But of course, in my time spent in the overseas centers, then that's when they are very forthcoming what they've been doing and using. And yes, in those countries, I have seen the case of drug abuse from vaping, because the liquid that they use is actually contains things like CBD, which I mentioned earlier in my talk, all these illicit drugs. Yes.
We have another question. In a remote area with problems of scarcity of medicine, what the most they have is for opioid toxicity is benzodiazepines. So what must they have to cure the use of this frequent disease?
Sorry, so what do you, sorry, I don't get the question. Meaning, what do they give for opioid overdose, or what do they, because
I'm assuming what do they give for opioid overdose if they don't have benzodiazepines?
But for opioid overdose, the antidote is actually naloxone. So if the patient is very obtunded and there is no naloxone to give, then the treatment recommendation would be to support the airway. So you may have to either intubate the patient and ventilate the patient till the drug wears off. So we don't give benzodiazepines, but if the antidote is actually naloxone. I hope I answered that question.
Yeah, actually, that question was a bit trickier. Doctor, for the last question today, do you think the increase in drug abuse is due to poor management of mental health by the medical practitioner?
I don't think so. I think, I mean, the answer would be no, because I think mental health issues are very complex. So it may not be, well, there are some patients who are depressed or they're upset and then they go on to overdose. Yes, then that would be, that can happen regardless of what their psychiatrists have done. Of course, there may be some cases where the care could be optimized, but overall, I would say that, for drug abuse, sometimes it could be just the person wanting to try something different, like I mentioned, peer pressure, or with the internet, it's quite easy nowadays to just go online, go into the drug forum to read about a certain drug. And the drug forum actually are very informative. They'll tell you what class this drug is, how does it work, how would you feel. And I think with our, with all of us, especially the young, being very techno-savvy, these information can be easily accessible, easily accessed, and also the ability to get drugs online is much easier than 10, 20 years ago. So I think that actually contributes more to the rise in cases of drug abuse, more than the suboptimal management of mental health.
Okay, doctor. Thank you, Dr. Chan. I would like to say thank you again, Dr. Chan Ling, for sharing her time for a talk, and also we managed to answer most of the questions. To the dear participants, the questions that are not answered will be answered during our forum session later. Just to say thank you again, Dr. Chan. And at the moment, we're going to have a 15-minute break from now till about 10:50. We'll start back again at 10:15 with our third talk for today. Okay, thank you.
Thank you.
All right. Welcome back to the second week of the Emergency Medical Seminar Series 2023. We will continue with our third presentation now. Our third talk is Clinical Management and Hospital Response to Mass Methanol Poisoning, a Philippine Experience by Dr. John David Comandante. Dr. John graduated with the University of Manila in 2013, attained his specialty training in emergency medicine in 2018, and completed his subspecialty training in 2020 in the field of clinical and occupational toxicology. He is currently the emergency medicine and head section of toxicology, Hospital Eng Makati in the Philippines. He has authored and published many articles related to toxicology. The screen is yours, doctor.
Good morning, everybody. I'm Dr. J.D. Comandante, and I'm here to discuss the clinical management and hospital response to mass methanol poisoning, our Philippine experience. And we'd like to share to you the learning objectives for this presentation. First, to discuss a case of methanol outbreak involving a contaminated alcohol drink managed at the Philippine General Hospital. To discuss the clinical management of methanol poisoning and our hospital response to the influx of patients. And to discuss critical lessons learned during the event. So, mass methanol outbreaks has been already a global concern. And in fact, this is actually one of the posters presented by MSF in reference to methanol outbreaks. It's usually caused by alcohol substitutes or methanol contaminated alcohol drinks, which is actually produced from fermentation or illicit distillation or those with poor quality control. It has been prevalent according to WHO in developing countries. And there is actually a very high case fatality rate, as high as 40%. And recently, in the years, it has been exacerbated by COVID-19 pandemic, like their experiences in Iran and other countries. So we had a similar outbreak here in the Philippines in December 2019, before the COVID started. There was actually an outbreak of what we call a lambanog. Lambanog is a traditional Filipino distilled palm liquor. It's like the coconut vodka of the Philippines from either coconut or nipa palm sap. And it has an 80 or 90% proof, or 40 to 45% by alcohol after single distillation. And in single distillation, you can produce as high as 11.4 to 18.2%, which was actually prevalent in this case. The acceptable levels of methanol is only 0.1%. And in that moment, the Philippine Food and Drug Administration actually posed an advisory on the danger of using this particular brand of lambanog, which actually contains these levels of methanol. So in that day, we received actually 2 calls in different hospitals in southern Luzon, which actually had already total of 4 deaths in 2 separate hospitals, and 1 already died, in fact, no, and it was actually already referred at separate hours in the poison center. We were able to already alert, since we were actually already inclined that this could be a possible methanol outbreak, and the respective agencies has already been alerted. We also alerted our triage officer for possible consults. At around 5 p.m., and yes, there were no subsequent coordination, and we were just actually informed only 30 minutes prior to the activated of code triage that indeed there will be influx of uncoordinated patients coming from Laguna, where the hotspot is. And this prompted us to alert our hospital for preparing ourselves for the influx of patients and increasing our surge capacity. By around 6:30, we were able to complete our ICS structure. Then patients are started to be diverted to different poison centers. This is actually a rundown of what happened. So this is actually a total of 7 days of outbreak that we have been continuously receiving calls. So receiving patients, aside from the calls we've been receiving, as there are actually simultaneous influx of patients in different parts of southern Luzon. In total, we received 18 red, categorized as symptomatic and stable vital signs with exposures to lambanog, 88 yellow patients with symptomatic but stable vital signs, and of course the exposure to lambanog, and 21 asymptomatic and stable vital signs with, again, the same exposure. So what steps have been done when we responded in that event? We were able to cohort our emergency department. At the time, we were actually renovating our emergency department. So there's actually a makeshift ER that we placed a specific segment for red patients, a specific segment for yellow patient, and a specific segment for green patients. We were already, recall system has already been in place, and we already assigned who will be actually in charge of treating and supervising the patient. So red was in the toxicology service was focusing on the red. Then all of the medical services are treating the yellow patients, and family medicine has been treating the green patients. We, at that time, we were already in the process also of managing simultaneously calls and actual patient. We simultaneously developed an algorithm which involves triaging, treatment, and their criteria for discharge. We were able to divert actually almost close to above 150 patients tagged as initially as green into triage to different poison centers available in the Metro Manila. So majority of the red and yellow stayed in the Philippine General Hospital, and most of the initial triage as green were diverted to other poison centers for further observation and treatment. All of the patients has been referred to ophthalmology for emergent ophthalmology consult, and emergent nephrology is actually, referral is actually also done in cases of emergent hemodialysis. We were able to establish the staging area for antidotes, medical supplies, and mechanical ventilators in one area as to centralize all of the supplies in the emergency department. So this is actually the total. So we can see in the first day, we received 73 patients. Again, majority of the yellow and red stayed at Philippine General Hospital, and we were able to divert green patients to other hospitals. And these were actually continuous admissions and referrals to the Philippine General Hospital. Particularly, you can see still an increased number of patients coming in even on the second day of outbreak, until we receive a total of 127 deaths. In total, more than 500 patients have been hospitalized in 8 centers with total of 12 deaths. This is actually the profile of what we got in the Philippine General Hospital. This graph shows you the age distribution of patients we received. And this is actually the estimation of amount of the lambanog ingested. Majority of them would have at least 1/2 to 3/4 of the lambanog, no? And the majority are males. This is actually the mean time from the last intake with the range as listed, the mean duration of hours of drinking, and majority of them only drank the lambanog without any other co-ingestions like beer or brandy, which is actually the most common co-ingestions in this case. And most of them presented with abdominal pain, almost more than 90% nausea and vomiting. Following the principles of acute poisoning management, of course, this would involve emergency stabilization, clinical evaluation, minimizing absorption, enhancing elimination, administration of antidotes, supportive therapy, and observation and disposition. We were able to manage our patients at the Philippine General Hospital. So first, those needed intubation were intubated. In fact, we had already at least 3 patients intubated on the first day. And we were able to successfully give fluid resuscitation and cardiovascular support. And then, unfortunately, during that time, when we received the first wave of patients, 1 patient died. The rest of the red patients was discharged improved with no persistence of ophthalmologic complications. They were managed according to your usual coma management, and all of the patients were given thiamine or electrolytes, particularly potassium and magnesium were corrected, hypoglycemia was addressed, and metabolic acidosis was definitely corrected. Most of them would be asked of the timing of ingestion. But as we know, methanol will always present in delayed presentation. It does not actually present within the first few hours of drinking spree, which is actually almost evident in the case. As you can see in the average time, majority of them would already have more than 48 hours from the time that they ingested and the symptoms develop. General physical examination and neurologic examination was performed, and of course, baseline fundoscopic examination was performed, particularly those who are symptomatic. Unfortunately, some of the laboratory tests, particularly the confirmatory tests, are not available in our center. Also, the osmolar gap was not calculated at that time because we don't have serum osmolality. Some of the patients underwent neuroimaging, at least to see whether their coma is due to other causes or there could be development of cerebral edema. So again, going back to the clinical evaluation, of course, we wanted to see if there was actually a history of drinking. Most of the patients, yes, admitted to ingestion of that certain type of lambanog. And there were actually clusters of symptoms observed. And at the 12-hour, which is actually the minimum time that you can see effects of methanol as part of the pathophysiologic mechanisms. They would actually present with feeling of hangover, nauseous, unwell. Some would present with chest pain. Again, I mentioned about nausea and vomiting and abdominal pain. Majority would have subtle hyperventilation, and of course, most importantly, visual disturbances. I've received also some patients, but not in this case series, that some will actually present with coma and 24 hours. So again, continuing with the management. So again, there's no role actually for minimizing absorption, at least for methanol poisoning. And I have already mentioned about hemodialysis, no? And actually 3 of our patients underwent emergent hemodialysis. In terms of antidote, no, there is actually your classic board exam question, or your usual antidote for methanol poisoning is fomepizole, which actually blocks the alcohol dehydrogenase enzyme that would actually um, inhibit the formation of more toxic metabolites from your methanol. And at least, which is actually available to us, is your oral ethanol. We even don't have the IV ethanol. So for some of our patients, we've had given them oral ethanol, and I'll be explaining later. Majority of them were given, of course, arterial blood gas, and this were actually our criteria for giving bicarbonate based on the pH and the bicarbonate levels. Gladly, through the generosity of the Methanol Institute, we were able to procure fomepizole for the first time in my experience, that I was able to provide fomepizole for my future methanol patients through Dr. Hofda from University of Oslo, and to the Methanol Institute in Singapore. So this was actually the table demonstrating of how you would give ethanol in your patient. So we used gin or vodka, which is actually 40%. And based on the recommendation, we had given a loading dose of 2 ml rather per kilogram, and a maintenance dose of 0.5 ml per kilogram per hour. Although logistically, this is actually difficult because you've been giving at least 0.5 ml of alcohol for almost more than 50 patients, no? So what we did, but of course this is not actually there should be a level that you should maintain at least for serum ethanol, and we were not able to monitor the blood alcohol levels for such. But in our experiences, we at least have given 2 ml, still the loading dose, but give it every 4 hours for logistical convenience. We have yet to see and analyze what happened in the administration of 2 ml per kilogram per hour in our patients, and there's actually a retrospective review of this. And to continue their supportive management, some of them were actually admitted to ICU. Again, I mentioned about 3 undergoing hemodialysis, and this is actually the indications for hemodialysis and methanol intoxication. The most common indications we used are actually those recommended by the extracorporeal treatments, or the XTRIP, in poisoning work group, which involves a pH of less than 7.15, severe visual defects or coma, or worsening vital signs, kidney failure, or levels of serum methanol as here. So what were the lessons learned in this incident? You know, at this time, I was still in training. I've learned so much in terms of management and hospital response to mass incidents. No? So one is their coordinated responses during chemical incidents. I have learned the role of toxicologists and poison centers during outbreaks. Of course, health algorithms help a lot. And case definition is very important, particularly for methanol. And I've learned the pathophysiologic mechanisms more in depth with the actual experience in methanol. So I'll share it to you one by one. So first, the internal alert systems and preparing for hospital response. At least for our experiences, we were able to do the following in terms of increasing your search capacity. Remember your 5S approach. Recall systems has been in place, triaging, effective triaging. Of course, what is actually different, at least for toxicologic patients, is that you should give a space for delayed manifestation. Some would really present as if they were green, but eventually, after sufficient observation, they will have the manifesting signs and symptoms already. So we were also in our last ammonia mass casualty incident, triaging was also effective, and delayed manifestations were taken into consideration. Of course, if your hospital would have your CBRN team, especially if there is actually a role for decontamination and even for administration of antidotes, because antidote giving, particularly ethanol, is actually an unconventional procedure for nurses, and it would really require training. So those specialized nurses, particularly our toxicology nurses, will be more comfortable in giving these kinds of treatment. And of course, activation of the incident command system. And later I'll be sharing with you what would be the role of some toxicologists in the incident command system. I've learned that in the poison control centers, you would actually have your specific roles. The poison control centers will have operational activities in the chemical incident response, like I'll be sharing later. Of course, you will be also the focal persons in monitoring possible delayed effects. There is actually cooperation with preparing rescue management plans if needed, in this case none, laying down recommendations, procedures, guidelines for response to chemical incidents, and what that is actually what the algorithm will help a lot. You would actually also do rational antidote supply. In our experiences, we have limited folinic acid, so we reserve the IV folinic acid to those critically ill, and we administered folic acid to most of our patients. Provide training for medical personnel and other rescue workers assigned to respond to chemical incidents, and cooperating in preparing analysis and follow-up studies of chemical accidents and proposing improvements. So those are actually the role of your poison control centers. What have I've learned, and this is actually an example of a network of toxicologists within our poison center, and we have actually collaborated. It is only possible to divert some of the patients, in the light of challenges in referral system, but in our network of poison centers, we were able to transfer some of our patients in the poison control centers within the Metro Manila. And there are actually 3 poison control centers. And usually, you would note that your poison control centers would actually act as an emergency operation centers during times of disaster. So these are actually some of the operational activities within the poison control centers. And, we've been treating some of our patients, but remember, we are also responding to calls referred to us outside because we have already been informed of the Sentinel event. And provincial health decided, since Philippine General Hospital is one of the end referrals for poisoning, they decided all of those exposed patients be brought to Philippine General Hospital, and that happened. Focusing treatment, we were able to focus our treatments on critically ill patients and those with lesser triaging. We were able to supervise them in large sets, and that's also with the help of our algorithm developed at that instance. And logistical support, I can remember at the time when I was also the senior fellow at the time, I was also functioning both in operations, in making sure of logistical support. And when our public information officer came in the Philippine General Hospital, I assisted him at least in the information needed, especially those theoreticals for methanol poisoning, at least to assist him in media briefings. Some would actually function as coordinators. Again, it's an emergency operation centers, and some will actually be responding pre-hospitally. So those actually the roles, at least guided, no, by some of the toxicologists. No? And the integral role of toxicologists in the incident command system is mostly under the planning section. You'll be having health-specific roles labeled as medical specialists or mostly technical specialists in our nomenclature, or in Hicks nomenclature, it's actually incident consultants. That is actually specific for this case. Like for example, in chemical incidents, there would be a need of technical specialists. Sometimes you can be assigned to safety. You can be also assigned as responding in an incident per se under the operation section, or if you'll be treating your responders, fellow responders, under the logistics section. Again, I would always emphasize that algorithms really help a lot. It enabled us to treat multiple casualties, focus on treatments on most toxic patients. So that was the role of the toxicologists. We focused on the red because the yellow, hopefully the algorithm we gave to the medical services helped. It helps treatment by quote unquote non-tox patients. They extended our treatment outside of PGH by this algorithm, and it standardizes procedures and protocols. Another second to the last is case definition. You know, it's very difficult to diagnose methanol poisoning, but in this case, we clearly had an epidemiologic linkage, a cluster of similar signs and symptoms, and this is actually the culprit. In reality, as I mentioned, even what we've experienced, diagnostic tests are really limited. No? In some centers, they would have their serum osmolality, then they can actually compute for what we call the osmolar gap, or even blood alcohol levels. But in the setting, of course, of mass casualty, those resources are also limited. And if it's actually available, like in our case, we were able to send for serum methanol levels, but the turnaround time actually gave us at least 5 days, which is no longer very useful in our clinical setting. Currently, we don't have at least point of care testing, and I know they had been developing already. I hope it's already in the testing phase, a breath analyzer type of methanol testing. It's difficult to diagnose methanol poisoning in the absence of history, especially if you had ethanol as a co-ingestion, because it will prolong the effects because your ethanol will compete with your methanol. Hence, what the author suggested is that if you would have patients with severe metabolic acidosis of a known cause, maybe you would want to consider methanol as part of your differentials. Lastly, the pathophysiologic mechanisms. Of course, some of you would already know this, but for review, again, this is actually where your methanol would have. It will be converted from methanol to the toxic formic acid, no, formaldehyde, through these enzymes. And your antidote, specifically your ethanol fomepizole, will competitively block the conversion of methanol to formaldehyde first. And that would actually also explain in the setting of lambanog ingestion that there were actually delayed manifestation because your aldehyde dehydrogenase first will metabolize your ethanol, then your methanol. And giving your antidote hopefully will actually prolong so that the mode of elimination of methanol is actually through respiration. That's why allowing them to hyperventilate to excrete the methanol is actually one of the strategies involved. And in the pathophysiologic mechanism, the term coined by one of the experts really in methanol poisoning, Circulus hypoxicus, because of the formation of formate that would actually inhibit your mitochondrial cytochrome C oxidase in your electron transport system complex 4, that will actually give you chain of um, cascade of toxic effects, particularly ocular toxicity and damages in your organs, causing multi-organ failure, and the formation of your formate and inhibition of respiration would actually give you lactic acidosis that would actually exacerbate increased formate toxicity and goes around and around in the late stages of methanol poisoning. Hence, that would actually give you a presentation of such. No? So, in summary, and these are actually some of the pitfalls that one clinician should also consider if you are actually faced with methanol poisoning: delayed diagnosis because of failure to consider methanol poisoning in differential of metabolic acidosis of unknown, failure to consider that there are actually multiple victims in this case because of a source, or there could be contamination of alcoholic beverages, failure to appreciate that the absence of early symptoms and the presence of normal anion gap or a small gap does not exclude a potential toxic methanol ingestion, failure to observe all patients with whom known or suspected methanol ingestion until a methanol level can be obtained, failure to give enough ethanol during hemodialysis because ethanol is actually hemodialyzed as well, and failure to have visual function formally assessed by an ophthalmologist. And with that, I end my presentation. I would like again to thank Dr. Joby Biag for the research that she'll be presenting in our next convention and the post-incident evaluation for this. And again, Dr. Chenery Lim and Dr. Nothofda for the invaluable support and advising us during the outbreak. This is me during the methanol outbreak. And thank you for listening in my presentation.
Thank you, Dr. John, for that wonderful speech regarding methanol poisoning. We'll move on to our next talk today. Our fourth and last talk for today will be entitled The Crashing Tox Adult Patient by Dr. Mohan Jambugulam. Dr. Mohan is an assistant professor in the Department of Medicine and Clinical Toxicology Unit, Christian Medical College in Vellore, India. He attained his MBBS degree and MD General Medicine from the same college, Christian Medical College in Vellore. He has co-authored many publications on a wide range of medical issues. Presenting Dr. Mohan.
So today, last talk, we will discuss the crashing toxicology adult patient. So presentation to emergency, usually they present in a very critical condition, those who ingest unknown poison. The challenges that we face when we approach these patients while trying to resuscitate, they have very incomplete, uncertain and erroneous history. So the most of the time details are not very clear. So in such a situation, what is required is an organized, targeted resuscitation. And usual ACLS protocols, which is used as a general approach in managing cardiac patients who develop cardiac arrest, is suboptimal in managing these particular group of patients presenting with unknown poisoning. So what are the objectives from this session? It's a brief overview and the approach, how we will discuss how to approach these patients in terms of resuscitating critically ill poisoned adult patient. So what are the components? Components are history taking, first priorities, rapid first look, which includes examination, monitoring and testing, and systemic evaluation, that is ABCDE approach. So let us see what are the initial history details that we should collect. So we should try to inquire if the patient is awake from him, or if patient is unconscious, family members and other relevant members should be thoroughly asked about the details of the event that has happened, about the poison that he has taken. And history taking must be very quick, but yet should be able to cover all the aspects, so that we'll try to get a clue what exactly has happened. And we should always ask the relatives to go back and check the surroundings for clues what kind of poison he would have taken. are any empty containers that are present or not. And also check the victim's pockets, shirt or a pant pockets, and see whether there is any leftover poison that he has ingested. So past medical history also very important. Any chronic diseases, any medication use, especially drug abuse history is very, very important. It's very important to approach or consult poison information centers in a situation where we don't know what is a poison that patient has presented and come. So at the same time, as we are taking history, we should always remember that simultaneous and immediate resuscitation should happen. So what is the role of poison information centers when trying to see what exactly the poison that patients would have taken? So this is, for example, we get a call to our poison center related to these kind of compounds where the details are not exactly mentioned. So they contain like potassium lactate, fillers, carriers. So such a patient in such a situation where patient took this and presented with vomiting and breathing difficulty, there was cyanosis, saturation was very low, respiratory system was examination was clear, and his normal PaO2 levels and his oxygen saturation was not improving. So when they consulted us, with our experience, with our database, we could straight away tell them that this particular compound could cause what is called methemoglobinemia, because it may contain nitrites or nitrates which oxidize the hemoglobin to cause methemoglobin. So what we have advised them is to do simple bedside test. We get calls from very, very small hospitals, remote hospitals in India, readily available co-oximetry to assess the methemoglobin levels. So just looking at the color of the blood on the gauze piece, this is the patient's and this is a control blood, which you can see chocolate brown color. So based on this, we advise antidote, that is methylene blue, to reverse methemoglobinemia that has happened. So this is another scenario where poison information centers play a role. Like one case scenario where 34-year-old mother along with 2 kids presented with coma and shock. They all had dilated pupils and ECG was available, and treating doctors did not know what poison the parent, mother and children would have taken. So based on the ECG, we certain findings helped us to arrive at the possible diagnosis. Could be a TCA poisoning here, where you can see the prominent R wave in AVR lead, which is more than 3 millimeters, and there is a wide QRS complex. So based on these ECG alone, we could make a diagnosis of probable TCA, probably amitriptyline poisoning, and we immediately advised antidote, sodium bicarbonate. So we could reverse all the toxicological effects of amitriptyline. So very, very important to approach poison information center when there is in doubt about poison that patient has ingested. So next aspect is first priorities. So first priorities are resuscitation team leader should play an important role when a patient arrives to the emergency department. So he should ensure that adequate number of team members. Emergency department is equipped with adequate capacities to manage these kind of patients. And also ensure the safety of healthcare workers, because many patients often present with exposed to highly toxic compounds. So which while resuscitating leads to the risk of exposure to the healthcare workers also. So sometimes there will be multiple causality or mass causality incidents happen. So a lot of victims may come to the emergency, and victims may be contaminated with highly potent toxins. And other challenging is how to do surface decontamination. Some patients with highly contaminated, highly poison compounds. So while decontaminating, healthcare workers may get exposed. And also disposal of soiled clothes with chemicals. So these are the certain challenging tasks while resuscitating these patients, and team leader has to ensure that safety of healthcare workers is ensured. So adequate PPE has to be worn as mentioned in this. And these are the certain scenarios where we have encountered. We get a calls from various mass incidents from industries around our poison center. We always make sure the team is prepared. We prepare adequate information brochures and send them so that they're well equipped with the team members and capacities to manage these kind of victims. So you can see this like styrene gas, ammonia gas leak, lead arsenic gas leak in a lead plant. So various incidents that happen where we have to be thoroughly equipped and make sure healthcare worker safety is ensured. The third aspect is rapid first look, examination, monitoring, and testing. So examination, monitoring, and testing. So the examination should happen, it should be a toxidrome oriented physical examination, which is very, very important in approaching patients with unknown poisoning. So we should cover all these aspects. So if you look at this picture from head to toe, you can see first is altered sensorium. So it could be three things: whether the patient is awake and alert, or patient is hyperactive, agitation, delirium, psychosis, then you know that it could be anticholinergic poisoning or sympathomimetic agents. If it is a depressed, drowsy, stupor, or coma, you know that it could be benzodiazepines or opioids. Assess the pupil size, miosis, mydriasis, or pinpoint miosis. We know that it's a cholinergic toxidrome. If it is a mydriasis, it could be sympathomimetic or anticholinergic toxidrome. Pinpoint pupils characteristically seen in opioid overdose. Examine the mucous membranes, moist, dry, or presence of any copious secretions that gives a clues to the various types of toxidromes. You in cholinergic toxidrome, you can see copious secretions, whereas dry mucous membranes you see in anticholinergic toxidrome. Sweating with severe sympathomimetic toxidrome. And also examine the skin for sweating, dry, raised temperature, again anticholinergic toxidrome. Drug injection marks, so sites of injection where they usually administer, that also should give us a clue whether the patient has taken any drug of abuse and come. Check the pulse rate, blood pressure, respiratory rate, very, very important. Presence or absence of bowel sounds is very, very important. So that absence of bowel sounds, we know that it could be opioid poisoning. Presence of or exaggerated bowel sounds you hear in cholinergic poisoning. Check for urinary retention, which is again suggestive of anticholinergic toxidrome. If you are suspecting envenomation, look for any fang marks or any other features of local or systemic envenomation that patient has developed, especially neuroparalysis, where they will have a proximal muscle weakness. You should examine for neck holding time. Ask the patient for count single breath up to 30, and also check for any paradoxical breathing is there or not. So these are the signs of impending neuroparalysis secondary to probably snake bite with envenomation. So these are the normal values. One should always try to remember, memorize them, so that when you approach a patient, you know that which are abnormal. And you also should know common cause of hypotension, bradycardia, and tachycardia. And these are the normal rectal temperature, oral temperature, and what is a life-threatening hyperthermia. And these are the various agents that can cause changes in body temperature. So just to see one case, one 30-year-old male ingested a pesticide 3 years ago, developed multiple episodes of vomiting, diarrhea, profuse sweating, and breathing difficulty. He had bradycardia, hypotension, tachypnea, saturation was low, pupils were miosis. Diffuse crepitations heard over bilateral lung fields. So what is a toxidrome? So based on just about the examination that we discussed, it could be probably cholinergic toxidrome, and then try to see what could be the pesticide here, and further management can be done. So approaching toxidrome wise, doing a thorough examination, toxidrome oriented examination helps us to arrive at the possible diagnosis and consider appropriate antidotes. So another case, a 40-year-old male ingested unknown number of seeds from a plant 4 years ago, developed hallucinations, delirium. On examination, he had tachycardia, hypertension, dry skin and mucosa, dilated pupils, urinary retention was present, along with elevated body temperature. So what is a toxidrome? It's straightforward anticholinergic toxidrome. Here probably a dathra seeds that patient would have taken. A 40-year-old lady ingested an unknown number of tablets 6 hours ago, found to be sleeping on her bed and was unresponsive to voice or pain stimuli. Arrival to emergency department, GCS was very low, heart rate was 70, blood pressure was 90/70. The rest of the system examination was unremarkable. So this is a simple sedative toxidrome. So where you have, after looking at the history and examination, you know that this is a possible sedative toxidrome. Then you will know what are the possible differential diagnosis, whether to give any antidote, you can decide. 20-year-old man injected a drug into his forearm with a syringe during a party 1 hour ago. Patient was brought to casualty by his friends. Very low GCS, 7/15, heart rate was 60, blood pressure was 90/50, bradypnea was a respiratory rate was only 12/12 per minute, pupils were pinpoint. The rest of the examination was unremarkable. You know what is a toxidrome, right? So this is a opioid toxidrome. So here the pupils were pinpoint and bowel sounds were absent. So that was a clue to say that it is a possible opioid toxidrome. Here, 18-year-old man ingested unknown tablets, developed vomiting, followed by tremulousness and agitation. He had tachycardia, hypertension, pupils were dilated, and profuse sweating was present. Rest of the examination was unremarkable. It's a sympathomimetic toxidrome. The clue here was profuse sweating. Whereas In anticholinergic toxidrome, you see a dry skin. Here you will see profuse sweating. That is the difference between anticholinergic toxidrome and sympathomimetic toxidrome. So this is a list of I mentioned. It's very, very important to go through this, memorize them, and remember always when we approach a patient, because toxidrome approach, toxidrome oriented physical examination helps us so much in arriving at possible diagnosis of unknown poisoning in patients who are critically ill. So whereas a patient who presents with stupor or a coma state, how we can approach this is an algorithm that we follow here. So 3 things that should be examined: pupils, vitals, and bowel sounds. If normal pupils, normal vital parameters, normal bowel sounds, it's possibly sedative toxidrome. If the pupils are dilated, tachycardia, dry mucous membranes, dry, warm, flushed skin, bowel sounds are absent, urinary retention, this could be anticholinergic toxidrome. Next is blood pressure. If the blood pressure is elevated along with anticholinergic toxidrome, then it could be a severe pure anticholinergic toxidrome. Whereas if there is hypotension present with wide pulse pressure, that means the compound that patient has taken possibly causing both anticholinergic toxidrome and alpha-1 adrenergic blockade. That's why patient is having hypotension. Whereas patient is having meiosis, bradypnea, shallow breathing, bowel sounds absent, then it's possibly opioid toxidrome. And also remember grade 4 OP poisoning with coma, cholinergic toxidrome, and also sometimes that are not included in this flowchart, that also we should remember. So sedative toxidrome, these are the possible xenobiotics that can cause. These are the various various xenobiotics that can cause anticholinergic. And we know opioid toxidrome caused by opioids, and central sympatholytics. So always we should consider differential diagnosis also when we are trying to get the clues while doing examination. Not just the poisoning that you should think of. You should always look for any organic causes. Always look for signs of trauma, use that patient would have taken, seizures, and other organic causes always to be looked into and should be ruled out while making the final diagnosis that this presentation could be due to the unknown poisoning that patient has taken and come. So monitoring and testing: simple bedside tests, cardiac and pulse oximeter, random blood glucose, arterial blood gas levels, ECG to look for QRS and QT interval, urine tox screen if it is available for any psychoactive drugs, specific drug assays like paracetamol poisoning or any other specific drugs that we are suspecting. If any animation is present, we do in India we 20-minute whole blood clotting test and other clotting tests to look for any hemotoxicity. So the last aspect is systemic evaluation, that is the ABCDE approach. So what is ABCDE? We all know that A is airway stabilization, B is breathing, circulation, disability and neurological stabilization, E is exposure and elimination. So let us discuss each one in this ABCDE. So airway stabilization: patients with airway compromise, dictum is intubate immediately. You will not be trying to see what patient has taken and other methods. You will not be doing it immediately. You have to secure the airway. That is must. That has to be done. Whereas patient is having sedation without airway compromise, only just mildly sedated, even if the GCS is very low, what we can do is we can wait and monitor, use appropriate antidote and see whether we can reverse the sensorium. If inevitable due to airway compromise, then we have to intubate and secure the airway. Always rule out hypoglycemia and other reversible causes of depressed sensorium, which is causing respiratory depression here, so that airway is compromised here. So a dictum is, if the airway is compromised, whatever the poisoning it is, whatever the patients presented, we have to intubate immediately. So 20-year-old man injected a drug. This is an opioid toxidrome that we have just discussed. Will you intubate immediately? If no antidote is available, let us say we don't have naloxone here, there is an impending respiratory failure, intubation has to be done and airway has to be secured. What antidote can be used? Naloxone. So we know this is a naloxone protocol that is standard regimen. First dose 0.4 mg IV stat, wait for 60 seconds, then second dose 0.8 mg, third dose further 2 mg, up to 4 mg we can give. If patient requiring repeated doses, we may have to give infusion, naloxone infusion. The goal here is, by giving naloxone, we are trying to reverse the respiratory distress and depression, not the consciousness. So the aim of giving any antidotes when patient is having respiratory depression along with depressed sensorium is to reverse the respiratory depression, not to reverse the CNS depression. That is very, very important while considering appropriate antidote. So 40-year-old man bitten by a snake, he developed swelling over the foot. He developed ptosis and single breath count was only 10. Neck holding was very weak, unable to complete a single sentence in a single breath. So probably a cobra bite with local and systemic envenomation. Do you intubate immediately? Yes, because patient is already having signs of neuroparalysis. There is impending respiratory failure. We should immediately secure the airway by intubating. Any antidote along with anti-snake venom, we should give neostigmine here, probably because it is a cobra bite where neostigmine can reverse the effects of venom that is binding to the postsynaptic muscarinic receptors in neuromuscular. So 40-year-old man with unknown tablets, this we have discussed is a sedative toxidrome. Do you intubate? If no antidote is available and there is impending respiratory failure, then we have to intubate, same as opioid toxidrome. Is there any antidote available? Yes, flumazenil can be used provided there are no contraindications. So flumazenil antidote has a little controversy. People tend to use it without even looking at clear indications. But we should remember that it has a very, very clear indications. The most two important indications are flumazenil should only be given to reverse the procedural sedation in patients who do not use chronic benzodiazepines. That means a patient was given a benzodiazepines for a sedation purpose. To reverse that, we can give flumazenil, who was not taking chronically benzodiazepines. Whereas in young children with isolated benzodiazepine overdose with severe CNS depression and ataxia, again, child was not on benzodiazepine before for any seizures or chronic use, then these are the two indications where we can give flumazenil. Contraindications for flumazenil use is if patient has taken a proconvulsant like TCA injection, tricyclic antidepressant. Suppose if the ECG is showing there is a QRS widening, prominent R wave in AVR, or any other features of TCA overdose, we should not give flumazenil because it can seizures. And TCA again can cause seizures. So there is an increased risk for seizures. That's why flumazenil should not be given in such a scenario. As part of coma cocktail, should not be given. So there is an olden practice of giving thiamine, naloxone, dextrose, and flumazenil should not be given. Altered mental status with already established seizures or suspicion of seizures should not be given again. Patient taking benzodiazepine for a seizure disorder. If somebody already been taking benzodiazepine for seizure disorder, comes with overdose now, you should not give flumazenil to reverse it because patient can develop precipitation of seizures. Iatrogenic benzodiazepine overdose caused by treatment of status epileptic also should not be used. So airway stabilization has to be done in a rapid sequence intubation manner. Pre-oxygenation should be given. Neuromuscular blockade should be considered appropriately and secure the airways. Subsequently, in certain special situations like OP poisoning or cardiac glycoside poisoning, when we are intubating, it's better to use rocuronium or vecuronium, and succinylcholine should not be used. And sometimes we may have to consider securing of airway when patient is awake itself. That's called early intubation by awake approach. So here a patient who has taken organophosphorus compound presented before 3 hours ago, and he developed respiratory depression along with impending respiratory failure. What is the next step in management? So intubate if there is impending respiratory failure, followed by start on antidote atropine, bolus and infusion. Then pralidoxime should be considered. What muscle relaxant do you use? Non-depolarizing muscle relaxant should be used like Vecurium. Do not use depolarizing muscle relaxants like succinylcholine, which can worsen the organophosphorus poisoning. So 35-year-old man accidentally ingested bathroom cleaning acid 1 hour ago. He developed a severe throat pain, dysphagia, vomiting, and blood-stained contents. On examination, he had stridor with obvious respiratory distress. His GC score is 15/15. So he's awake, but he's having already airway compromise. So how do you secure airway? So in a patient with corrosive ingestion with airway compromise, emergency tracheostomy is the best way to secure the airway. Because by considering trying to intubate, there is a risk of aspiration of the gastric contents or an acid that patient has taken or a cleaning agent that he has taken, corrosive agent, that there is a risk of aspiration to the lungs. So IV fluid resuscitation should be given, shift to ICU, no gastric lavage should be done. Once stabilized, consider upper gastroendoscopy within 24 hours to rule out any corrosive injury and placement of Ryle's tube and further subsequent management. So next is breathing. So we have discussed about airway stabilization. In breathing, whenever there is a compromise of breathing, administer oxygen to those who are critically ill. So this is a dictum again. We should remember any patient who are present to emergency department who are critically ill, sensorium is very low. The first thing when they come to emergency we should do is start oxygen. You don't even check pulse, you don't even check blood pressure, you don't even do any other intervention. First thing that has to be done when a patient who develop depressed sensorium and we don't know whether the airway is compromised or not, when they come, first thing we should do is start oxygen with a mask. Very, very, very important. Because while trying to see the cause, while trying to take the history, while trying to do the examination, the compromise of airway and abnormality in the breathing can be compromised, and that can further worsen the patient's condition. And many toxins interfere with oxygen and ventilation, that should be remembered. So these are the various physical asphyxiants and chemical asphyxiants that can affect the breathing, so that oxygen delivery to the tissues will be affected, so that we should be aware of. So I will not be going in detail. This is just the slide that I have mentioned here, how physical asphyxiants and chemical asphyxiants can affect the breathing delivery of oxygen to the tissues. So aspirin poisoning, support breathing and avoid intubation. So a 26-year-old lady with acute overdose of aspirin with respiratory distress, tachypnea and hyperapnic. So what are the treatment options? So what we can consider is start urinary alkalinization, IV sodium bicarbonate infusion, then hemodialysis in severe salicylate poisoning. Do you intubate immediately? No, consider sodium bicarbonate and dialysis to avoid intubation, because these patients with aspirin poisoning, salicylate poisoning depend on the respiratory drive to maintain their ventilation. So by intubating, which may lead to decompensation of the patient's condition, so patient can go into a respiratory or a cardiac arrest. So avoid maximum to intubation. Consider the antidote, that is sodium bicarbonate, and in severe cases dialysis, so that we can get away by not intubating this patient. 40-year-old man with toxic alcohol ingestion 4 hours ago presented with vomiting, diarrhea and severe metabolic acidosis. How do you manage this patient? So give sodium bicarbonate, avoid unnecessary sedation, maximize the minute ventilation and hemodialysis and antidote. Again here, patient with severe metabolic acidosis, they'll have a very deep, shallow breathing, acidotic breathing. So there, try not to avoid intubation, because try not to do intubation because they depend on the respiratory drive here. By intubating, sometimes it may lead to sudden decompensation. So try to use the antidote and avoid the sedation and maximize the minute ventilation and hemodialysis and antidote. So next is circulation. These are the abnormalities can be seen in circulation, like asystole, hypotension, bradycardia, monomorphic wide complex tachycardia, polymorphic ventricular tachycardia, neurocomplex tachycardia. This is the management of asystole ventricular fibrillation. This has to be an AC according to the ACLS protocol that we all know of. Management of hypotension. Any poison that is causing hypotension, it can happen through myocardial depression or vasodilation, where we should give initial fluid resuscitation with isotonic crystalloids. Not responding, vasopressor should be considered, then followed by specific antidote. And always bedside screening echo should be done in cases of refractory hypotension to look for severe LV systole dysfunction, and various other therapies like glucagon, high-dose insulin therapy, intralipid emulsion, methylene blue, ECMO should be considered subsequently. So here is a calcium channel blocker poisoning. Patient has come. What is the antidote you give? You can give calcium gluconate. If BP is not responding, these are the various therapies that we can consider, like vasopressor, glucagon, high-dose insulin therapy, intralipid emulsion, methylene blue, and ECMO. So this is a comparison of management of these are the various agents that can cause bradycardia with hypotension. So like digoxin, beta blockers, and oleander poisoning. So this is an example we see commonly in India. This is a oleander fruit which contains cardiac glycoside, mainly causes AV blocks, high degree AV blocks along with severe bradycardia. Here we use atropine, and in severe cases we use temporary cardiac pacing. So this is the difference between management of calcium channel blocker and beta blocker poisoning. If you can see here, if there is only bradycardia, first you give atropine boluses. And if there is a sinus SA or AV block, you have to consider temporary cardiac pacing in both the scenario. Whereas in calcium channel blocker poisoning, if there is a hypotension, consider calcium gluconate as an antidote. Whereas in beta blocker, if there is bradycardia with hypotension, you give IV hydration, dobutamine or isoprene infusion. Not responding to calcium gluconate for CCB poisoning, then you consider vasopressors. Then you go to the next level. If the patient is having refractory hypotension with impaired cardiac contractility, these are the things we should consider: glucagon, adrenaline, high-dose insulin, intralipid emulsion, methylene blue, and ECMO. Here also similar. when patient is having impaired cardiac contractility with hypotension. These are the methods that should be considered to improve the blood pressure and cardiac contractility. So this is a wide complex tachycardia causes, like we have already discussed tricyclic antidepressant where we should give sodium bicarbonate. This is the wide complex tachycardia with hypotension case scenario, which we already discussed, where we have given sodium bicarbonate to reverse the effects of wide complex tachycardia. Second is polymorphic ventricular tachycardia. These are characterized by QT prolongation. These are the various agents that can cause, where we should give antidote magnesium sulfate. These are the certain examples where patients had a QT prolongation. We use what is called QT heart rate nomogram. One side is a QT, one side is a heart rate. By placing a joining point, if it is more than this line, we use magnesium sulfate to reverse the risk of torsades pointus. I will not go into it. And comma cocktail should not be used routinely in all these patients. And these are the various things for neurological disability, like dextrose infusion if there is a hypoglycemia, naloxone for respiratory depression, flumazenil we already discussed, and thiamine if it is appropriate. And physostigmine again cautiously should be used when there is a ICU setting and you have atropine readily available, then you can use physostigmine. So seizures, benzodiazepines are the drug of choice, and refractory we can use propofol. But remember, don't use phenytoin. Phenytoin, when we use it, it can again precipitate arrhythmias. In a xenobiotic-induced seizure management, try to avoid phenytoin. So next is exposure and elimination. This is gastric decontamination and enhanced elimination. So these are the various methods of enhanced elimination. So enhanced elimination, these are the three things that we commonly do it. One is multidose activated charcoal, alkaline diuresis, and various extracorporeal therapies. Multidose activated charcoal, these are the various indications. What we commonly do is amitriptyline poisoning, carbamazepine poisoning, and phenytoin and phenobarbital. And these are the contraindications that we should remember. And this is the forced diuresis. We use it for lithium poisoning or toxin-induced hypercalcemia, where we try to expand the extracellular volume by giving normal saline so that the xenobiotic can be eliminated. And this is a manipulation of urinary pH by alkali. We try to eliminate the enhance the elimination of certain xenobiotics. So this is characteristically used in salicylate poisoning, phenobarbital, 2,4-D poisoning, which we commonly see here in India. And extracorporeal therapy, we know that dialysis, hemoperfusion, and plasma exchange. Just remember the principles of extracorporeal therapy. It all depends on three things. One is protein binding, volume of distribution, and molecular weight. If a xenobiotic has a more protein binding, then that compound can be eliminated by or can be removed by plasma exchange. Whereas if it is between 80 to 95%, we can use hemoperfusion. Those xenobiotics that have a less molecular weight, we can try either hemodialysis, CVBH, exchange. So three things: volume of distribution, molecular weight, and protein binding. If more protein binding, more molecular weight, high molecular weight, plasma exchange. If it is less molecular weight, less protein binding, hemodialysis or continuous veno-venous diafiltration or continuous veno-venous hemoperfusion. These are the various xenobiotics and indications of hemodialysis and other various extracorporeal therapies that I have mentioned. I have taken it from XTRIP guidelines, which is a site where the guidelines for extracorporeal therapy in various xenobiotics is mentioned. So just to summarize, remember how to approach a patient with unknown poisoning. ABCD's approach is very, very important. So patient, when they present to emergency department, remember that with unknown poison, remember that they'll be very, very critically ill. They present in extreme states. So a systematic approach is very, very important. And ABCD's approach is very, very important. Remember what are the components of it. Always treat the patient, not the poison. Don't waste your time in trying to identify the poison. So treat the patient. And remember, when they come to emergency department with a depressed sensorium, always start the oxygen immediately. Use antidotes when necessary. Also remember contraindications. Resuscitative measures to be followed according to the guidelines. And poison control centers play an important role, especially poison information centers, where they can readily provide information and guidance on managing a patient with unknown poisoning who are presenting critically ill to the emergency department. So these are my references. Thank you.
Thank you again for your speech. From what I understand, that as clinicians, to treat an acute crashing tox patient, we need to be extra vigilant with a high index of suspicion. If not, managing them will be very difficult. So now we have actually arrived we are done with all our 4 talks and we have arrived at our Q&A session, our forum. So I would like to invite all the speakers to turn on their cameras at the moment. Dr. Rian, Dr. Patrick, Dr. Vanessa. Okay, fortunately enough, Dr. Vanessa from Chorai Hospital is joining us today as well for the forum. So this forum session, actually, we are going to, your participants can ask their questions either directly to to a speaker, or you can post your question ups in the question box, and we'll try and discuss and give you the best answer possible. So for the first question, actually, I wanted to direct this question to Dr. Vanessa, actually. Good morning, Dr. Vanessa. Can you hear me?
Yeah, I can hear you well.
Yeah, Dr. Vanessa, actually, the first question is, what is your view on medical marijuana? Should it be legalized? And what is Vietnam's view on this, actually?
Okay. In Vietnam, I think the form marijuana is not very popular until now. So about methamphetamine poisoning is more popular, more common when we met in the clinical or in the hospital or in the emergency room. For other substances, I mean, for the drugs abuse, they're less, especially, for example, cocaine, because I listened the lecture before, so I see it in Singapore, right? In Singapore, so when she showed the graph, so I see that look like the cocaine is is very popular in Singapore, but in Vietnam, we don't have I haven't seen any case of cocaine here in Vietnam. So most of case we have in about methamphetamine. For heroin also decrease now, and but also they also use for marijuana, but look like the import. Yeah, the import from the US or from somewhere else. We didn't know, but it's also not very popular. Yeah, this is different from other countries where I see it. Yeah.
So cocaine is more prominent in Vietnam compared to
no cocaine here. Yeah, I haven't seen any case of cocaine here. Yeah. But methamphetamine, GSP, GSP also have sometime. Yeah, we have a case of GSP. But also, but recently, we have several cases when they because they cannot import the GSP to Vietnam recently, so they changed to another substance like I remember the dibutadiol, right? Yeah,
Yes.
because after metabolize, it will become a GSP, similar GSP. Yeah, after metabolize. So now, recently, so they use that. Yeah, for to replace the GSP, and for marijuana, sometime. Yeah, but not very popular.
Okay. Thank you, Dr. Vanessa. Dr. Mohan, what is your view on this issue, actually?
So this is marijuana related, no, sir?
Yes, yes.
Sir, we don't see much marijuana patients with marijuana injection coming to our emergency department, but we do get calls related to marijuana injection, and where these are all isolated cases, not like a mass incidents that happen, where with severe CNS depression, and sometimes they'll be in delirium. So patient would have been left at home for many days without taking care of. So these are the states they present with, and when doctors call us, they wouldn't have known whether patient has taken a marijuana or not. So how we advise is we look at the patient clinical status, uh, examination details, then try to see which toxidrome they are presenting now, and we give a supportive treatment. Sorry, sir, I missed your specific question. What is the specific question, sir?
Actually, the specific question is regarding legalization of marijuana, and what are your views on it, actually? Is there a role for medical marijuana in India?
No, sir. It is not legalized at all in India. It's highly punishable offense. Whoever either takes any form of marijuana, both in the form of dried leaves or even in the oil. So now it is hashish oil, no, which is very, very prominent. It's becoming more and more popular here. Whatever form marijuana that is available, it is punishable offense. So it is not legalized. In medicine also, we don't use it at all here.
Okay, doctor. Dr. Mohan, just another question. Earlier you said regarding a crushing tox patient, why do we avoid phenytoin in seizures actually?
Yeah, so I was telling you there that phenytoin is a sodium channel blocker. So there is a risk of arrhythmias. So many of the poisons, many of the xenobiotics, when they take and present, they already have a risk of arrhythmias because of that particular inciting agent that they have taken. And if they have seizures, when we try to treat with phenytoin, there is an increased risk of arrhythmias. There is increased risk of cardiotoxicity. So that is why the standard classical teaching is that avoid phenytoin when you manage a patient with seizures when they present with unknown xenobiotic ingestion. So you can use benzodiazepines, which are the safer anti-epileptic agents.
Okay, doctor. Dr. Ryoko, actually, one question to you. Is there any antidote for over-the-counter drugs like Benadryl, diphenhydramine?
The main treatment are supportive care, I think.
Okay. I mean, there's no specific antidote for it.
Yes, no, it's don't have any antidote.
Okay. Just regarding a bit on methanol poisoning, is there any cases of methanol poisoning reported in Japan?
In Japan?
Yeah.
So methanol poisoning is there is a small amount in Japan, I think.
Yes.
Then I have a question for the methanol poisoning to Dr. Patrick.
Yeah. Dr. Patrick? Unfortunately, Dr. Patrick is not here. Maybe Dr. Vanessa can shed some light regarding methanol poisoning.
No, I just want to say something, have some comment about it. Because when I listen about the lectures about methanol poisoning, so I have a question that because in Vietnam sometimes I see that some physicians, so they can have a wrong diagnosis for methanol poisoning or misdiagnosis, because when the patient came to the emergency room or some emergency department and the patient have a severe acidosis, and then sometimes, for example, if they coma or seizure, and then so they will, and also for the history, they will heard about drink alcohol. So they see they can conclude immediately this for methanol poisoning. So to me, I always consider it's right or wrong. When we stand in front of the patient, like have with the history, with ring wire, and then after that become coma or become confusion and acidosis later. In some cases, very severe, so the patient also have a respiratory failure and severe acidosis. But if you ask more about detail about history, so most of case, I saw that the patient drank a lot of wine, ethanol. So have you? So I would like to ask you, all of you too, if you have experience on that. So I think sometimes we need to be careful for diagnosis methanol, because the patient can drink a lot of ethanol and the clinical condition still show you like severe acidosis too. So this is the same. When for severe case, ethanol poisoning and methanol poisoning look the same. Yeah, so let's see, we cannot say immediately. So this is the case methanol. So if you think that if you have a wrong diagnosis, so this is a case methanol poisoning, but actually this is ethanol poisoning. And then you use antidote, so you use the ethanol because you will give more ethanol for the patient because you think that it's methanol poisoning, right? So if in that situation, so you will make for the patient with more severe ethanol poisoning. So let's see the important point when I see from my patient in my country. So let's see, I'm not sure that because sometimes I see that many cases, so they just say methanol poisoning. So I make a question, why we have a lot of care methanol poisoning? And also, I don't know about for your country, do you think that is the same that, and what make you, what you make sure that that's even methanol poisoning? Because we can calculate the concentration of ethanol in blood of the patient. If you know about amount of the ethanol when the patient drink and how long they drink, and even about how many percent of that ethanol. So you can calculate about the concentration of ethanol in blood of the patient. So let's see, we can explain everything in condition. So let's see, I always feel sometimes confused when if physician just call me and ask us about it. This is a case methanol poisoning. So I'm just wondering, and I just want to make sure that if we can do anything to make sure that this is a methanol poisoning. And also in Vietnam, we cannot do about the format, because from the Dr. Hofda. So I like his lecture because he teach us a lot about that experience. So if I don't know if your country, if you also have the test of we can test the format in blood or not, but here in Vietnam we cannot. Yeah.
Can I take photos? Can I take photos with that screen also?
Okay. It's just my comment and question. If you have experience, you can share to me so I can understand more about situation in your country.
Take the laptop.
Take it from the screenshot of this one.
Oh, good morning and welcome Prof. Khaldun to our forum. Really nice to have you here.
Yes, thank you for all the speakers. It was really interesting discussions. Yeah, just we hope that Dr. Patrick will be able to join us as well, so he could answer the question about the alcohol intoxication in the Philippines. Because the situation in the Philippines in the past was that they used this concoction of coconut from coconut fermentation, and they used to use this for parties or for special occasion, and there were a few cases of mass intoxication from the impurities of this alcohol preparation. So it's a kind of a part of the tradition as well. So in Malaysia, for example, we have rice fermentation to produce wine in certain cultures, and they use this to, for the celebrations for that particular group. For example, in the Orang Asli or from the natives of Sabah and Sarawak, so they use rice wine. So, but it's about I don't know it's how good the production is will also determine how much impurities is in there. And but so far, most of the intoxications is because of volume consumption. Means the higher the volume, then they get the effect of the alcohol. And of course, depending on how good your liver is as well. So we don't know what is the status of the people who attending the functions. So they might get the effect more than the others who has optimal liver condition. So it all depends. And how do we prevent it? I'm not sure because it's already deep rooted in the culture. This is something that they need to have for that particular occasion or for that particular celebrations. So we can always perhaps be on standby in our department when we have this type of celebrations going around, and we can anticipate that a few may be turning up in our emergency department. So the process is the same of all the kinds of the alcohol intoxication management. I think it's the same perhaps in India as well. Or from Vietnam. Japan, I'm not sure. Do you have? I know Japan has a lot of high number of alcohol consumption, part of the culture as well, I think. But I think it's getting less and less over the years. So people are opting for other beverages other than alcohol, especially among the young people. It may not be a good news to the manufacturers, in Japan, but yeah, people are opting for maybe non-alcoholic beer or other beverages, coffee, for example. Yeah. So maybe you guys can comment a bit, but because this is something to do with culture as well. So things change as well, and young people are opting for other things other than the tradition that is being practiced. So maybe you guys can comment. It's quite interesting discussion, I think, how this dynamic may or may not affect the rate of intoxications or poisoning in our community.
So in Japan?
Yeah. What about in Japan? I know. Yeah.
Yeah, a high concentration of alcohol are available in Japan. So many young people are transported for acute alcohol intoxication. But about methanol, in Japan, it is not very common for mature to brew their own alcohol in
Yes.
their house. This is a known cause of suicide and murder. And then so
I think
fewer.
that's a that's a very interesting point, because as you said, in Japan, they don't have, they don't make alcohol themselves. They just buy it, which is already quite rather safe. But for example, that these countries, like for us in Malaysia, we still have community which make alcohol, make drink themselves, and that can cause a problem, right? So
Yeah.
So that's why I said this consumption, your intoxication is probably from the volume that they take. But for us, there could be other impurities also in there because of this lack. Even though you have very high consumption of alcohol, but you rarely see these impurities poisoning. So that's very interesting, I think. Yeah. What about India? Maybe Dr. Mohan or Dr. Whoever, and Vietnam as well.
Sir, can I speak? Yes, sir. Sir, we see a lot of cases of toxic alcohol ingestion and presenting in very severely ill, critical condition. So we do see methanol ingestion, ethylene glycol ingestion. The challenges are we don't have readily available assays to detect ethylene glycol or methanol concentration. So we have to mainly approach based on the clinical presentation. So usually they'll be comatose, or they'll have severe abdominal pain, persistent vomiting. Then they can have a severe metabolic acidosis, high anion gap metabolic acidosis. And if in extreme cases, they would have already developed renal failure. So that is how they present with. So our diagnosis is based on clinical and certain lab tests like increase in osmolality and high anion gap metabolic acidosis. And another challenging is we don't have readily available antidotes. We don't have fomepizole or IV ethanol. Sometimes we use oral ethyl alcohol. But if they have presented late, already 48 hours over, there is a established renal failure, then only option is hemodialysis. So that is how we approach. It's quite a big problem in India. Many rural places, people take these locally made alcohols which are contaminated with these alcohols. So these kind of mass causalities happen that come in newspaper, that group of people ingested this and they've died before they go to hospital. And hospital doctors, small hospitals, they're not equipped with this information, or readily hemodialysis is not available, antidotes are not available, so proper information is not available. So what poison centers we do is we try to help them by giving proper information, so that appropriate referral can be done to a higher center where intensive care and facilities and hemodialysis facilities are available. Thank you, sir.
Dr. Vanessa, what about in Vietnam? You also having a problem as well? You have a lot of festivals.
So in Vietnam, if the physician have a diagnosis for the patient that's methanol poisoning, they will do the dialysis for patients. So because we also don't have an antidote for fomepizole, we don't have that. But they're also scared about if they can give the ethanol to the patient if they have a diagnosis with methanol poisoning, because in their mind they think that maybe that is the fake ethanol or something like that. So let's say they don't dare to use ethanol in clinical to treat the methanol poisoning. They only use the dialysis. That if they
I think
confirm the methanol poisoning. Yeah.
Okay. We have Dr. Taufik as well available from Indonesia. Maybe Dr. Taufik would like to give some account of. I think they have also similar issues with alcohol in Indonesia, where some impurities got into the drinks, and this is maybe counterfeit products as well. So, Dr. Taufik, you have any comment? Any recent incidents?
Yes, thank you, Prof. Aldun. Well, I think in our country is very amazing case for the alcohol or ethanol intoxication, because in our country, especially in our hospital, we call the case of intoxication is not pure of is ethanol or methanol. We call in here is oplosan, alcohol oplosan. So I think in our country and our people in Indonesia is very familiar names. Yeah? We call the alcohol oplosan. So the patients came to our emergency department with the specific and specific clinical manifestation, and the mild symptom is blur vision. The patient after they drank the alcohol oplosan, and the severe manifestation is the patient is already unconsciousness, and from the laboratory, especially from the analyzed gas blood, is severe metabolic acidosis. So actually, in our country, especially in our hospital, is does have the antidote, especially for measles. So we can manage the patient with the last action is of course with the hemodialysis. So after we can do this treatment, so we can see what is the effect from the patient. If we manage the patient is not if we manage the patient immediately, I think the patient can survive as well. But if we late about to treat the patient, of course the patient is very dead in the last death in the from the last management, like that of profile. So the alcohol oplosan is very special. Actually, the person mix some drink, especially big cola, yeah, and they mix with the uh, other other drink. It could be with the drug or with the ethanol, as like we call the topi miring, and the other arak acid, and with the name of the thing we call uh, the traditional alcohol, we call the arak putih, like that profile. So the alcohol oplosan is we can be difficult to know about what is the specific content from that cause the problem from the patient
Okay,
with
so
the toxidrome symptom.
yeah. So the question now is, if we have these kind of problems where the impurities get into the drinks, though. So I know, if, for example, in Japan, they don't really have these issues because of perhaps the manufacturing and also the laws in place in terms of production and control. So we are seeing probably all this problem because maybe there are still lack of implementation of the law regarding these impurities getting into our drinks. So yeah, so I think I go give back to Rabindran. Maybe you have any questions for the panelists?
Yeah, actually, thank you, Prof. Actually, I have one question from the panel box regarding legalization. This question is actually open to all speakers for their view. Regarding legalization of hard drugs, which is happening in first world countries like Norway and Sweden, where they legalize usage of hard drugs. So by doing this, surprisingly, they have found a reduction in usage of these hard drugs and also a reduction in transmission of viral diseases, retroviral diseases, surprisingly. So just want your view on this, Dr. Mohan.
I think that's a difficult question to answer. In India, it is not legalized. So that is a challenging. But I have heard that some countries, few countries have legalized, especially marijuana. So countries like India, legalizing is a very challenging. Many oppositions will be there, knowing that there are some health benefits. So my view is that though there are certain health benefits, but the ill effects or extreme toxicity that can happen with these drugs, we should not forget. So I feel legalizing has its own problems. So it's a very challenging question to answer always. So if you ask me as a doctor, do you go with the legalizing medication? I would say no. So rather than that, if it is medicinally has a proven value, therapeutically can be used, use its byproducts if it really shows a benefit to the patient. But legalizing it has various implications, both in terms of affecting the health of the victims, because there is no control over it. Even if legalized to say that only moderations are allowed, it's very difficult to legalize it, especially for India, like such a big country. Maybe small countries or therapeutically there are definitive benefits. Maybe this can be thought of that legalizing.
What do
What
you
about
think?
Japan? Yeah.
Yeah.
What about Japan?
Sorry, doctor. What about Japan, Dr. Ryoko?
So in Japan, regulation against illegal drugs are very strict. Legalization of marijuana, for example, it's spreading around the world, but it is still very difficult in Japan now, I think.
So in Japan, they still not legalize the use of hard drug. Am I right?
So some people recommend the legal use of medical marijuana and other drugs. So however, even recently, a university student was caught solely for marijuana possession.
In Vietnam, have you legalized any drugs?
No,
And
even e-cigarette also not illegal here.
it's not also. Oh gosh. Okay. Right. Okay. We had some issue, right, Rabindran, in Malaysia. There's a e-cigarette thing.
Yes.
There was some debate about it. Can you just let us know a bit about that?
Regarding the e-cigarette, recently they've been found that e-cigarettes not only contain nicotine. We know it doesn't contain any tar, but only nicotine. But some of the substances in the e-cigarettes, it contains illegal drugs. Some contain marijuana extract, and some contain heroin, amphetamines. So there have been cases where it has been sold illegally in Malaysia. So the number of cases have been going up, and we have had a few cases presenting to ED where patients have come with the symptoms of a symptom of like a toxidrome, but we are actually unsure of what drug is it. It's not purely the nicotine in the vaping fluid. From our point of view, that is our stance at the moment. Yeah.
Yeah, so I think what prevention, and also I think the question by Corinna Stitch, that is actually a very interesting concept where you try to approach a problem through the awareness in the public about the effect and so on, which is correct. But at the moment, as you rightly put, there was not much emphasis. I think it will take more effort, I think, and more budget requirement for such an effort to occur. Yes, we have seen the outcome, but we also have seen people abusing that as well. So how do you deal with those who abuse, even though it was made legal, and causing them to, ended up in our hospital with various level of severity of the poisoning. So, for example, if we legalize it for medical use, are we going to be certain only those with the prescription going to get it, or some others will also, attempt to get it? So it's going to be left with individual conscience about what is good for them or what is not good for them. So that is part of the, I think, measures that we can actually encourage in our society to be more conscious about or aware about the limits of things. So it's very difficult to turn that into a culture. It has to be culturalized. It has to be. It's not just like it has to be a habit of prevention. So that is a bit difficult when we had years and hundreds of years of very authoritarian kind of approach of doing things. So I really appreciate the question that is provided by Corina Stitch. For example, in Japan, in Germany as well, there are a few drugs that try to legalize, and we see a lot of things still getting abused as well. It's not necessarily go down in number, but perhaps also the severity of cases that can present to us. So yeah, but are we going to everybody can do anything and nothing is going to be punished for the or punishment approach as you mentioned it? I'm not sure. There must be a balance between the two, and it all depends on the psyche of the society in taking the safety culture into their own society. So yeah, anybody else would like to maybe comment about this? Dr. Mohan, is your society in India is a safety culture is going for the safety culture approach?
No, sir.
Yeah, so that's why I said, maybe if we can promote it more, then it will actually become a bit easier for this so-called preventive measures rather than legal punishment approach or in our countries, So it's all about changing the mindset of us, of our culture. So it is a tough one, yeah. But I can see the benefits of that, definitely. Right? When we can prevent, it's better than cure. Am I right? Yeah. So yeah. Vanessa, what do you think? Safety culture, prevention is better than cure in Vietnam. Is it going to be a
I agree.
reality?
Yeah, I agree with that. Because for poisoning, if it become severe, so maybe you cannot cure to the patient. But so that's it. Prevention is more important.
Yeah.
In poisoning, so that's it. I agree.
Yeah, I think it's every intoxication or every poisoning or even envenoming as well. We are moving towards prevention is better than cure. Yeah. But Japan has a very good policy on prevention is better than cure. There's a safety culture in Japan. What do you think? Have you seen it? Less and less people abusing so-called hard drugs or marijuana, for example.
So I think people, especially young people, are very interested in drugs, any drugs, like marijuana. It may be a relaxing method they find to distract themselves from the difficult everyday life. But however, they underestimate the addictive nature of its ingredient. I think we have to think about why they need the drug, not just get them off them.
Yes,
I
yes.
think.
Agree. So that's very interesting input that we have to think, why do they take the drug in the first place? That nobody really asked that question. And we sometimes, when we see patients in our emergency department, we just treat the physical. We do not see the psyche, the emotion, everything that goes pre why they take it. So that we don't want to address that issue, because we have to liaise more with our psychiatric friends managing such cases as well. This is a multidisciplinary approach to tackle such a problem. We have to address the root cause why people want to do that. So Dr. Taufik, any input about this? I know because Indonesia, for example, Indonesia is the largest Muslim country in the world, but we still have this issue of alcohol intoxication, for example. I know it may, it's a skewed kind of perspective where you say all Muslims don't drink alcohol, therefore Indonesia should not be. There is also another pressure that is being put to the society with that kind of belief. But things happen, and people always find ways that about using drugs and so on. So what do you think, Dr. Taufik? How can the society help prevent abusing such poisons?
Okay, thank you, Professor. As I think in Indonesia is that there are so many cases about the heart track, especially in case of the intoxication too. But the problem is there is never recorded properly. So, especially even about the investigation about the heart track. I think is in Indonesia is any case about the problem about the intoxication about the heart track this. So in our country, the issue is very very out of people let know about the problem about the heart track this. So actually from our institution is if you know about the case about the heart track this, so our management is actually is depend on the clinical, the severity, the level of severity of the manifestation, Prof. Because as we know, we don't have an antidote as well, and then so we can only just berdoa saja, Prof. So it's but
yeah, so we have to work closely with the legal system, right? So it's not just
yes,
about punishment, but we have to ask the root cause why such a thing still happened in supposedly a very close community where drugs and alcohol is considered haram, right?
yes,
So
yes,
that's very interesting to see how where the society as a whole can hold so-called the moral values for that for that kind of so-called abuse from happening, but it still happen. That's the thing.
yes, still
So
happen.
so how do we as a society can help reduce such abuse, right? So that's where the safety culture comes into play. How our legislation system, our authority deal with prevention and also, of course, the abuse side. Of course, those for you can't let go for those who will deal with drugs, right? They kind of sell the drug openly. That's obviously cannot happen. That is not legal. But in terms of the usage itself, as we learned from, for example, the alcohol issue in New York at one time, where they banned all alcohol from the street. People find ways to get alcohol through the shady method. That's where the gangsters come on, Al Capone and so on. So the moonshine and all this illegal trade. So too hard can actually cause more problems because they will find a way, but too lenient also can cause problems. So we have to strike a balance where we need to have the community itself, where individual member of the community have to play a role for the prevention. As I agree with Corinne Stitch talking about the school, how we approach in terms of prevention from the school system. So that could be another way where we try to teach our young, well, not teach, but to give them options, better options, perhaps. Nowadays, we say if we teach you, no, then nobody will listen, right? We have to say we provide you with the options, so perhaps more receptive. Okay. All right, Rabindran, any other questions?
Yeah, we have one last question actually. We have been talking all day regarding the side effects of marijuana. So there's one question here regarding what are the benefits of marijuana? Can marijuana provide is there any medicinal purpose of medical marijuana? Basically, that's the question. Can Dr. Mohan enlighten us a bit on this?
Personally speaking, I don't have any experience with using it as a for medical benefits. So sorry, I don't have any experience being marijuana being used for any medical benefits.
Yeah, unfortunately, it is more commonly used in the Western countries because it's legalized there. Unfortunately, in Asian countries, at the moment, for now, it is still not legalized in most countries. Maybe Thailand just recently.
Yes.
Yeah.
Maybe you can ask Prof. Sataria later. Because not just marijuana, there's also the ketum, kratom. Yeah, so those also has been in the limelight recently as well, this past few years, and Thailand is in that sort of leading role to make things legalized, and we'll see kind of a social experiment about it. We're still not sure which one they will choose, the marijuana or kratom. So yeah, Vanessa, what do you think?
I will visit the porn center in Thailand next week. Next week, so I will ask.
Yeah, and have fun too. Yes.
Yeah.
Yeah. So Malaysia, I don't think, right, Rabindran, we don't yet. There was a talk about only for research purposes, the use of such drugs or such marijuana or kratom. So it's at the moment is still under research. So that is allowing people to grow for research purposes, but not for consumption as yet. If I'm not mistaken, that's the situation in Malaysia.
Thank you, Prof, for your input. Okay, unfortunately, we have come to the end of our forum session today. Sadly, I would just like to thank Dr. Ryoko, Dr. Taufik, Dr. Vanessa, and Dr. Mohan for sharing some light on all your topics, as well as thank you to Prof. Khaldun for making the forum session more interactive. Thank you so much all for being here. And thank you to the participants as well for all your questions. We hope we managed to answer them as much as we can. So now we'll be moving to our Kahoot session. It's the last event of the day, actually. So the Kahoot is actually consists of 12 questions. I need all the participants to fill up, download the Kahoot app, enter the PIN, and you all can play this game consisting of 12 questions. And there'll be a winner at the end of this Kahoot session. And the winner can directly message us so we can proceed with the prize giving. So we'll start the Kahoot session now. Just give me a moment. Okay, we'll be starting our Kahoot session now. Okay, we have come to end our Kahoot session. For third place is Gunnar. For second place, JC. And for our Kahoot champion or winner, it goes to FH. So dear FH, kindly personal messages at the chat box, and we'll get back to you regarding your prize. Okay, unfortunately, we're at the end of our session today. I just want to say thank you to all participants for your attention for the last 4 hours. Really appreciate it. I'd like to say thank you to all our speakers, Dr. Ryoko, Dr. Chan Ling, Dr. Mohan, as well as Dr. John David, for sharing some of your experiences with us. I'd like to say thank you to our advisor, Prof. Khaldun, Dr. Amin, Dr. Irene, for guiding us throughout this process, and my EMSS team for helping put this together. Just before all of us depart, I would like all of you all to scan your QR codes for your MMA CPD points. These are for Malaysian participants. For foreign participants as well as Malaysians, we have our feedback form. Kindly fill up your feedback form so you all will receive your certificate within the next 3 days. So the webinar recordings on YouTube, you can watch it in 1 to 2 days time.